All right, so what we're going to do, we're going to hook up some lungs here. And I'm just going to do this little demo. I think this is probably the most important thing that you can have as you go through the PowerPoint here. Yummy! Mr. Pig's lungs. All right, these are your lungs. Aren't they gorgeous? All right, let's put these guys on a ventilator. My apologies to the RTs in the room. This is a ready ventilator, but it will get the job somewhat done. So anybody who's an RT or works with RTs can just like I know who we're all looking at. I'm not talking to anybody in particular. Any RTs can leave right now. Actually, no, I need them to fact check me. Okay. So this is a circuit. Do not RTs, please. This is a cheap circuit. I'm going to show you a little bit about how we're going to get this all to work. So how do we blow up lungs? Well, normally we have a diaphragm underneath that pulls down and inflates these lungs because the suction will pull down and inflate the lungs. We don't have a diaphragm on our Mr. Piggy here, so we're going to have to ventilate Mr. Piggy. He's not breathing on his own, so we are going to ventilate him. How can we ventilate lungs? Well, we could do a mask, but Mr. Piggy doesn't have a mouth, so we can't really do a mask. We are going to have to put an airway into Mr. Piggy here. So up on this side, you will see that I'm going to put in an airway here. We can use a tracheostomy or an oral ET tube. This one will go you can go through your nose or through your mouth and into your trachea there. This one is just a little bit thicker. So if you look at these two, you can see one is thicker than the other. They have different sizes. This one is, I don't know if you can see the numbers on these. I don't think you can. No, it's not that good of a webcam. This one is a 6.5 French. This one is at 8 French. So you can see that the bigger number is wider than the smaller number. The 6.5 is much narrower than the 8. I'm going to put the 6.5 in here because this is a narrow little airway. If I just put this in, this is going to be his trachea that's going to go around to here. I would put it here, but that's not how these guys work. So I am intubating my patient here. You can see that right now, this intubation would not really work because it will slide right out, right? This is going to slide right out. So if I try to blow air in through here, what's going to happen at the entryway? Some of it's going to come back out the entryway. So when we have these tubes in, most of these tubes have a balloon on the end of them here. We're going to inflate this balloon to obstruct the rest of the airway. That balloon will keep, if you cough or if you have secretions in your mouth, they won't go straight down into your trachea and infect your lungs. So this thing on the end of any trach or any ET tube is going to blow up the balloon on the end. So whenever you see these little valves, these little balloons, these are to blow up air and blow up the cuff. So on this one, once I put this is just air, and we will put air in and it will blow up that cuff. Okay. So we're going to blow that up in the trachea. We put this in the trachea and blow that up so that it is obstructed. And then we will start ventilating these lungs. One of the things I want to show you is the difference between something called positive end expiratory pressure and just regular ventilation. So this is ventilating with a mask. It's just a regular valve, bag valve mask. This right here is called a PEEP valve. You will hear me use the words PEEP and positive pressure a lot here. PEEP is positive end expiratory pressure, and that is basically resistance to exhale. End expiratory, so when you're exhaling, You have some resistance to exhaling. It keeps your lungs open. And the best way to show you that is to do this demo. So I am going to bag these lungs. Look at them growing. Oh my gosh. Nobody throw up on me, please. Nobody throw up. Let me turn on the light so we can actually see it. No, the light does not help. Okay. So we are blowing up the lungs, but notice what is happening after each breath. They deflate, right? That's normal. That's great. Do you see these areas that are not inflating right here? What would we call that? Areas that are not inflating. They're atelectic. This is atelectic tissue. The parts that are not inflating there, why aren't they inflating? They're collapsed, man. And just like a balloon, you know how some balloons, you got to stretch them in order to get the air in. Like if you just go blowing an air into a balloon, it doesn't go. You got to stretch it a little bit and then blow the air in. Well, that's lung alveoli are the same way. And you notice that after we stop exhaling, what happens to these lungs? We stop inhaling and exhaling on them. What happens to these lungs? All the air just flies out of them and they shrivel up again. Okay, so you can see them how they look shriveled. Well, we're going to change something. So you see how every time we inflate, they shrivel back down, right? We inflate and they shrivel back down. They inflate, we shrivel back down. Well, every time they get these little creases in them, this is damage. This is actually, you're looking at a bunch of alveoli. You're looking at a whole bunch of alveoli, all kind of commingled. And there are blood vessels around the outside of these. They're capillaries. Capillaries around an alveoli are only 1 cell thick. They're too small for us to see with our human eye. So they just kind of all blend together into a big pink mass here. But what I am going to do to help these lungs inflate better is give them some end expiratory pressure. Because when we do this, the whole breath goes in and the whole breath exhales out. Whole breath goes in, whole breath exhales out. Now we're going to put some resistance to exhale on there. So every patient that is getting bagged should have a PEEP valve on there because we keep some resistance to exhalation in here. We never inhale our whole breath and exhale our whole breath. You have to do like serious deep thinking to really inhale and exhale your whole breath. Let's put a PEEP valve on. And when I'm telling you about PEEP valves, let's see, there are numbers on the side, which of course this thing cannot focus up close. There are numbers on the side that go from at the very top, that's 5, 10, 15, 20. You're going to have to trust me there. Normal, our own PEEP, what we do for ourselves when we exhale is we hold on to some of our air. And that keeps our alveoli popped open. We give ourselves our own positive end expiratory pressure, and that is called PEEP. And our physiologic PEEP is about 5 millimeters of water. That's what we retain in our lungs to keep our alveoli popped open. You may see people who are having trouble breathing do pursed lip breathing, where they go, and they exhale out through pursed lips. What is that doing? When you exhale out through pursed lips, there's resistance to exhale, right? You can't just exhale all the way out. You're pursing your lips and trying to give resistance. That's going to increase your PEEP. So people who are having trouble breathing do this automatically. They go, they crease because their body knows they need to keep those alveoli popped open. So again, I'm going to show you what it looks like to add PEEP. So here's without, inflate, deflate. Let's do with PEEP. I'll throw the PEEP on, inflate, inflate. Look, they don't deflate as much with each breath. They stay popped open. And so the fact that we are keeping the lungs popped open means that we are stretching this atelectic tissue. And if I keep pumping these lungs with PEEP on them, that atelectic tissue will start popping open, because we're stretching it with each breath. With each exhale, I'm keeping some air in the lungs. And we see a big difference in the lungs, don't we? It's not deflating nearly as much. And so this is what we are doing to keep lungs from deflating all the way. If we let it go, it will deflate all the way. Notice this area up here. Watch it popping. I don't know if you can see this area up here. I don't know if you can see these atelectic areas. Check out this area over here, that dark red area. These are atelectic areas, and I am trying to recruit them and bring them in by just inflating this lung and not letting it deflate all the way. You can see how shiny it's staying. It's not getting wrinkly in between each breath. And so positive end expiratory pressure keeps our lungs from deflating all the way and allows us to take easier breaths in. Because if your lung is already somewhat inflated, then let's turn the PEEP up. I'm going to give him more PEEP. We're going to give him full on PEEP. Look at with full on PEEP. Now you can hear the exhale. That's the resistance. It's hitting resistance. It's not letting all the air out. And that's what's making that noise. But look at the lungs. All I did was increase that resistance to exhale. Oh my gosh, look at that atelectic tissue. It's almost gone. All that was resistance to exhale. And we have nearly got these lungs fully inflated. All we did was add PEEP. And so we are watching, the more you do it with you, I know it just, huh? Oh, that's a great question. What happens if we put in too much pressure? They'll blow. They will pop. They will pop a hole in them. They can. So we are just blowing this thing up. We're not going to blow them up across the room. But you can see how much healthier they look. All we did was add PEEP, guys. So sometimes your patient just needs this extra pressure. If we take the pressure off, look what happens to those lungs. So the moral of the story is, if your patient is having trouble getting air to pop open those alveoli and they can't do that incentive spirometer deep enough to get a full breath, they might need more pressure. So that's one of the ways we can get them pressure, is with this PEEP. Okay, we can put PEEP on your ventilators and on your CPAP and your BiPAP machine. So what I am going to do is, we have these 6 sad little lungs here. We're going to ventilate these lungs, if I can find the right attachment. This is have you seen these guys in your critical care clinical? This is, any RTs in the room, I'm not looking at anyone. If we have any used ones that are not broken apart by the weather here, I could use those. All right, let me find. So the reason I put that together like this is so we could have a ventilator circuit. This does allow us, if I have a suction, that we can just go in and suction out that catheter and pull it back if we want, so we can suction out that catheter without opening and closing the system. Because what's going to happen if we're giving the patient pressure and PEEP and we open this system, we're going to lose all of our pressure in our lungs. So let's turn on this machine here. And we're just showing you, this is just an introduction to why we ventilate patients when they're in respiratory failure. A respiratory failure lungs are going to look kind of cruddy. And every time the patient takes a breath with their own, let's simulate their own patient breath. So this is the patient going into respiratory distress. They cannot use their chest muscles to inhale very well. So these are their tiny little breaths. What are those doing? Not a whole lot of anything. So here's a respiratory rate of 40 with low, what we're calling tidal volumes. Tidal volume is the amount of air in and the amount of air out. So this is probably, if you take a breath in and out, it's probably around about 100, 200 milliliters in and out. But that is not what we can inhale. If we took an incentive spirometer and inhaled all the way in, how high could we get? How high do you get on that incentive spirometer? What do we ask people to do? We want them to get to 2,000 milliliters. Most people, that takes a lot of effort to get to that. In fact, some smaller people can't even get the full 2,000 milliliters in. Their lungs just aren't that big. So it depends on the patient, but your normal tidal volumes are around 200, which means this is what you're doing in your lungs. Okay, you're inflating them, deflating them, inflating. We're going to put the 5 of PEEP on because that's normal for us. So this is what most people are doing on a daily basis, is they're taking a big breath and exhaling, inhaling, exhaling, and that's what your lungs look like. As you go into respiratory failure, your lungs are not as strong, and so these are tiny tidal volumes. You're only inflating the top parts of your lungs when you take tiny breaths. Okay? Teeny tiny breaths are not useful, even with your 5 of PEEP. They're not doing anything. So if we increase PEEP and they're still taking teeny tiny breaths, helps a little bit, but those lungs still aren't inflating all the way. But you can see that tiny breaths do get better with higher PEEP. I've just turned the PEEP all the way up, and now the lungs are staying inflated. But most patients don't have any extra support, right? They're just on nasal cannula or something. Their lungs are not doing that well. So when lungs are not doing that well, and when we're only inflating these little tip tops of your lungs, what do you think your oxygenation is going to look like? It's going to look like crap because you're just not bringing enough air in to get around. And these parts of the lungs at the bottom, at the bases, aren't even getting air in them to exchange. So any O2 that gets down there isn't really a lot of O2 getting down there to exchange. Half of your capillaries aren't even receiving oxygen. So little tiny tidal volumes fast don't do much for you at all. So this patient's getting tired. He can't keep oxygen in him. His muscles are getting weak. They are getting sore. It's like asking a paralyzed person or a person with weak muscles to walk. They're not going to be able to do it. Patients with weak respiratory muscles aren't able to pull in enough air. So how are we going to get them air? We're going to try to push air in. So when a patient is in respiratory failure, it means they can't inhale air adequately on their own. Their muscles are weak. Their lungs are not pulling air in. Whatever the problem is, they can't get air in. So we have to push air in. We can do that 2 ways. You can do it through a mask, which we put a big mask on your face and hook it up to a machine, and that will push air in through a mask. That's non-invasive ventilation. Or we can actually put in a tube into your throat and invasively ventilate you. Both of them go to a ventilator. Non-invasive is called CPAP and BiPAP, and invasive is called ventilation, but they're both ventilators. So what we're going to do is turn this guy on. Oh, it helps if it plugged in. Look at my poor little piggy is dying right now. Piggy isn't going to make it. I promise this one demo will make everything seem a whole lot better. All right. What we're going to do is we're going to ask you guys to change a few things to get this pig better. So we have a couple of things we can work with. We can work with oxygen. We can work with inspiratory pressure, pressure into the lungs. We can work with expiratory pressure, resistance to exhaling. And we can work with tidal volume. So there are 3 elements to ventilating a patient: oxygen, pressure in, a resistance to pressure out, and tidal volume. Okay, tidal volume is that amount that you are moving in and out with each breath. So let's see what we've got. I'm going to be hitting this if I'm not. Okay, so it's on right now. Right now, I'm going to set it, and I'm going to tell you what we're setting it at. You want me to blow up the lungs? Oh. Are you sure? Who should I aim it at? Okay. Let's do a, okay, silence. It's going to keep beeping at me because this is not a good system. We're gonna change, so, oh, we can also add a rate. I'm not set yet, so. Piggy's having trouble right now because it's set at 4. So do you think 4 is a good rate for little Piggy? He's doing pretty good here, but that's because we also have. Right. The pressures, it's the alarm. All right, this is CPAP. This is 1 pressure. And it's going to keep beeping at me because. Oh, it's mad because the oxygen's not hooked up. I don't even know what happened to my backpack. Oh. Okay. So when you're on CPAP, I don't know if I can show you this. When you're on CPAP, it gives you 1 pressure to regulate. 1 pressure to regulate and a rate. I have 2 things that I can set on here, a rate and a pressure. What this is, it's set at a rate of 18 right now, but CPAP is waiting for the patient to take their own breath. CPAP is just continuous positive end expiratory pressure. So it is not full ventilation. It is waiting for the patient to take a breath. And when the patient takes a breath, it will push some air in. But this patient can't breathe, it's just a set of lungs. So CPAP is not going to work on this patient because I'm only allowed to give 1 pressure. And it is just a pressure resistance to exhale. This is not setting any pressure for the patient. It's not doing anything. Let me change this to. All right. So I am changing these. So my inspiratory pressure is 5 and my expiratory pressure is 5. And it is set at a rate of, let's give him a rate. We should be able to see here some breathing, but we are not seeing a lot of breathing going on because my pressures are not high enough. I'm going to increase, because this patient is not doing anything, I'm going to increase the pressure, inspiratory pressure. Let's go up on the inspiratory pressure. So I am pushing air into him now. Now do you see him moving? I had to go up on the inspiratory pressure to get air into him. He's not helping us with his muscles at all. So what we are doing here is I had to go up on my inspiratory pressure to see any movement on there. So I needed to give him more push in. The higher I move this inspiratory pressure up, the more air he gets in because I'm pushing it with more force, right? Higher the pressure, the more forced air in. So patients that are having trouble with their own breathing, you might have to push a little more pressure in there. We are going to put enough pressure in there to get inflation and deflation, okay? To get an adequate tidal volume, which means they're breathing in and exhaling out. This is not really helping his lungs become those big fat pink lungs we liked, right? So we are having inspiratory pressure going in. Right now, this is a pressure of 50, which don't RTs in the back say anything about the pressures. I have a high pressure of 50 to get these lungs to expand because he's not helping us at all. How am I going to get these things to puff up? How did I get them to puff up before with the bag valve mask? With PEEP. So our inspiratory pressure is high. We are pushing air into him to help him inflate, but now I want to keep him from deflating all the way. So we're going to change the expiratory pressure as well. And I'm going to change the expiratory pressure to, let's say, 15. Now, do you see a difference in how he's breathing? What happened now? Why is he not inhaling or exhaling? Because the pressure in is just as high as the pressure out. Yeah, We can't exhale. Where's your CO2 going to go? Nowhere. So we're going to have to make a balance between the inspiratory pressure in and the expiratory pressure out. They both can't be high because then you're pushing pressure in and not letting it out. So we have to have a nice balance between the air we're pushing in and the air we're holding in the lungs. Because if you push the inspiratory and the expiratory too high, there will be no ventilation. Ventilation is the rise and fall of these lungs. I'm sorry for the beeping. See, now there's a little bit of ventilation. I'm going to lower the expiratory pressure even more, and you can see a bigger change in your ventilation, right? Pressure in, pressure out. Those are real important. And you can see the higher the pressure out, the better our lungs look, but we want to still maintain ventilation. So this is the magic that the RTs do. We don't do this, okay? That's their job. They went to school for many, many years to learn how to manage the pressures on the ventilator. What we are doing is checking the pressures on the ventilator and looking for any side effects. Let's really high inspiratory pressures and medium expiratory pressures. And look at those beautiful lungs. All we did was add pressure. I didn't even give him extra oxygen. Look how much better those lungs look. Oxygen does 0 things to help your lungs inflate and deflate. Pressure helps more. So when your patient is not able to manage on just oxygen, what do they need? Pressure, exactly. And so when your patient is in respiratory failure, that's why we give them increasing support, pressure. I'm going to take them off the ventilator real quick. Just going to shut it off. Watch what happens to these lungs as soon as we shut off the ventilator and shut off the pressure. Bye-bye. That's the only thing keeping these lungs awake and inflated. Look how fast they deflate as soon as the pressure disappears. So a patient in respiratory failure, imagine these little poopy lungs. This is a patient that doesn't have enough strength to make their chest expand to pull air in. We have to then change it to pushing air in. So that is basically the respiratory lecture right there. We are trying to improve their ventilation. We can throw all kinds of oxygen on here. I can put the wall at 15 liters. Not doing anything for a patient that cannot pull and exhale, okay? So that is why when we are in respiratory failure, we put positive pressure behind it. If we don't want to put the breathing tube in, we put a mask on their face and give them pressure that way. You can see that the CPAP did nothing for ventilation. It just held pressure. The patient needs their own. With BiPAP, we can now change the inspiratory and expiratory pressures and give them ventilation because we can push air in and allow air out. Push air in, allow air out. With CPAP, there's only one pressure and it's just a resistance. You have to be able to pull your own air in. And a lot of patients, when they're tired, cannot pull their air in, which is why BiPAP is used more for respiratory failure patients because we can push air in and let air exhale out. But we can put a resistance on that exhale so the lungs stay open. Okay, so I think that's probably the biggest point for the respiratory lecture so that you understand. The other thing that we are going to throw into this is there is a lining around these lungs. And I'm going to use this as the lining around these lungs. This is a very highly technical piece of lining around my lungs here. Get in there. Get in there, piggy. Get in there, piggy. Oh, that's probably not big enough for my lungs to expand. I'm not going to do this. I'm going to get a bigger bag for next week when we talk about chest tubes. But imagine this is your pleural sac. Just like your heart has a sac called the pericardial sac, your lungs have a sac around them called the pleural sac. And in this space, there's not a lot of space in that pleural sac, but there's a little bit of fluid in there that will lubricate your lungs as they open and close so that as they hit this sac, they're not getting damaged or anything. But this is your pleural space. Now imagine you had a hole in your lungs there, where as we pushed air in, would that hole in your lungs, where would that air go? It would go into the bag, right? If we pushed air in, let's see if this works. Try it. Who wants to get blown up on? Lauren, you're in like, what is it? The Gallagher smash zone or whatever.
Right.
Where he popped, I don't know, that's kind of dating me. Popped the watermelon and he's like, we're in the smash zone. Let's see if this lung has a pneumo.
Trust me.
I'm gonna try and water seal this bag. Or air seal this bag. We'll see if this lung has a pneumo. If this lung has any holes in it, when we push air in, those holes are gonna expand into the bag, right? And it shouldn't come out into the atmosphere. It's gonna stay in the bag. Let's see what happens. Let's see. If not, I will do a better bag for next week. Okay, we're watching him. We're watching him inflate. He's kind of a little bit snug in that sack. I need to get a bigger sack for him. But look at him inflate. Really, our sack is not that much bigger than our actual lungs. I'm looking to see if there is air bubbling in here. I think I might even have holes in the sack here. It's probably not a best sack. But you can see it inflating and deflating within that sack, right? And I'm looking to see if we have a pneumo, because if we have a pneumo, we're going to have air gathering in that sac. Are we having air gather? Maybe not. Maybe this lung is intact. My other lungs have air holes in them. Well, I'm going to have to poke a hole in these lungs next week. Yeah, we're going to have to poke a hole in them to show you what we're doing. This lung does not have a pneumo. What would we see if he had a pneumothorax, which is a hole in the lung tissue? We would see that air accumulating in the bag because there's nowhere for it to go, right? I've got it occluded up here. So there's nowhere for that air to go. So the air would start swelling in that bag. What would it do to the lungs? It would smush them. So I'm going to bring another bag next week that's a little bit bigger and poke a hole in these lungs so we can see what a pneumothorax will do to our lungs. The same thing will happen if you get fluid in the space or blood in the space. If you get anything in that pericardial space, or sorry, the pleural space, I'm still in heart. If we get anything in that pleural space, it will accumulate over there and will cause swishing to the lungs. So these are really the concepts that we are looking for. I will leave this up and let you play. I'm just going to show you in the PowerPoint real quick. So that's the kind of the end of my demo. The pigs will come back next week. We will talk about the chest tubes and everything and how we pull stuff out of the chest tubes. A quick demo here. I'm going to review what we talked about the lungs, but I'm going to show you now chest tubes and why we do chest tubes. And I think this will help you understand. I'm gonna wonder if I can zoom. Let's see if it lets me zoom. I don't think I can zoom. So I might have to pick up a few things and bring them closer for the camera. Let me get my little lungs up. We're gonna start with the healthy lungs, and then I have a lung with pneumo. So just to review, just in case the last recording did not work out properly. We got my little pig. We got Porky. And we're going to get Porky inflated. Porky's not breathing real well. He's in respiratory failure. And he's in respiratory failure because he's not inhaling, exhaling. So if blood is flowing past all these alveoli, nothing is happening. If he's not inhaling proper amounts of oxygen, no oxygen could get into Porky's blood and no CO2 could get out. So the first thing we have to do is get Porky breathing again because he's not adequately respiring. So we have to, what do we have to do to get Porky respiring? Oxygen didn't work. I got the nasal cannula, the face mask on him. His oxygen sats are still 80, God, he's probably dead, but so we're going to try, we would BiPAP him, except that his airway is no good. I mean, he can't protect his airway. He doesn't even have it. So we can't BiPAP him because he can't protect his airway. He can't even swallow because he doesn't even have a mouth. So no airway. So what do we have to do to get him an airway? We're going to intubate him. You can also trach your patient, or you can't, but the doctor could. So we're going to intubate our patient because he cannot protect his airway. He could protect his airway. We could easily, if he had an airway, put a mask on him and ventilate him through the mask. This is the same exact machine. I would ventilate him through the mask, except it wouldn't work. So we are going to take this down. And we're going to put the breathing tube in. And then so that the air doesn't escape out of the breathing tube, what do we need to do? We're going to inflate it. So we're going to inflate that balloon so that the balloon stays in the trachea and does not leak any air. As the machine pushes air into your lungs, we want that air staying in the lungs, not leaking out around the tube out of your mouth. So that's what the tube is for. After they put in a breathing tube to a patient, how do we know it's in the right place? What do you do first? This might be a test question. Not the x-ray first. What do we do very first? They put the tube in. We're going to listen. Because when you put a breathing tube into an actual human being, or Porky, if we put this breathing tube into Porky here, down his trachea, what comes off first here? It bifurcates down there, but the right main stem comes first. The right goes off to the right, and then there's one a little further down that goes off to the left, okay, from the trachea. And so sometimes when they shove these tubes in real far, they go to the right. And then what are we doing? We're only inflating one lung. So the first thing after you put in a breathing tube, some people said capnography. That means that when they put the tube in, they are checking a color changing thing. They put a little adapter on the end of the tube. And that's looking for the first exhale after the tube's put in. Is there CO2? And if there is CO2, it changes color. So the first thing we're going to do probably is the capnography, because that will at least tell us that we're in the lungs. Because if you give a breath or two and it doesn't turn CO2 colored, where is it? It's in the stomach. So you can intubate, because when you put this down, there's two holes it can go into, the trachea and the esophagus. And they have to visualize the trachea. They have to physically move the tongue out of the way and visualize the vocal cords and go in between the vocal cords. I think I have a video somewhere of a bronch intubation. I'll try and find it when we go on break. But they will put it in through the vocal cords. So it should be in the lungs, but they do it because mostly they visualize intubation. So it should be in the right place. But the CO2, basically they put the thing in, wait for a breath or give a bag breath, look for the CO2 change. That means that's in the lung, but it doesn't mean it's in both lungs. It could be in the right lung. So the next thing after capnography is to listen for breath sounds on both sides after they're intubated. If you don't hear breath sounds on both sides, they may pull the tube back a centimeter or two to get it up, because if it's gone down into the right, they just have to pull it back up so that it's sitting in the trachea. It has to be sitting right at the bifurcation there to get air to both sides of the lungs. So if it's too deep, it will be in one lung or the other. So check your lung sounds after they intubate. And that's where after they put the tube in, you may hear someone say, somebody got ears on? And that's where they want you to check for both sounds, for breath sounds on both sides. Then after that, they will get the chest x-ray. Because we're not going to get a chest x-ray, find out it's only inflating one lung, and then readjust it. They're going to readjust that sooner than the x-ray. So that's the process for getting the tube in. There might be a test question on it. So, first would be capnography, second would be listen for bilateral breath sounds, and third would be the chest x-ray. But that's how we check for placement. We've done chest x-ray, and we have Porky all hooked up. So while we were doing the chest x-ray, we are bagging him with a PEEP valve, because when they're not ventilating well, we want to add positive pressure. So we would have put him on BiPAP or CPAP if he could have protected his airway with that positive pressure. But because he can't protect his airway, we are just going to inflate him. And I can see a pneumo here. Let me bring this up on the screen so you can see the pneumo too. Let's see. I can get this blowing up. As I'm blowing it up, check this spot right here. You see that spot right there? It's not a pneumo yet, but it's about to be. What is wrong with this section right here? Can you see that section right there? It's got a big air bubble underneath it. That is a piece of damaged tissue or damaged alveoli, oops, that is, or a collection of damaged alveoli that every time I put pressure in, you see it blowing up like like a blister. That is called a bleb. And those are just pieces of damaged tissue that under pressure could pop. And that is something that does cause a pneumo. If this pops, we now have air escaping out of the lung and into this cavity here. And that's what I'm going to show you next. So we watched PEEP last week, but just in case you forgot, or just in case that video didn't come out, I'm just going to do it for this one. I'm going to take PEEP off and bag him. You saw how pink and beautiful he was looking. When we bag him without PEEP, he gets pink and beautiful, but then he shrinks back down to shriveled and red. We want to keep him pink and beautiful and recruit those alveoli and get those alveoli popped open. So here it is with PEEP. You can see he doesn't shrivel down just as much, and with each breath, stays bigger and pinker. So that's what we want to do, and I want to do it permanently because if I'm the respiratory therapist, my hands are going to get tired doing this. So we're going to put him on the ventilator. And I think I got it so that it won't make as much noise this time around, hopefully. All right, let's get him on the ventilator. I could keep this on, not being bagged. All right. So we're gonna watch him intubated. And then what I'm gonna do is I'm going to give him a pneumo. I'm gonna put up my set of lungs that are already damaged. And we're gonna give him a pneumo, and I'm gonna show you why we're gonna do a chest tube. But let's get him inflating first. Let me get my ventilator working. See that? Come on, breathe. Breathe, little buddy. Okay. So what I have done is, at first, when he wasn't respiring real well, his inspiratory pressure was low. So what I did was I just said, this is just on BiPAP. This is not a ventilator. It's not on anything other than I put him on a rate of 6. So you can see he's not really breathing real well because he's on a rate of 6. That's barely adequate, right? So he's not breathing real great. So what I did was I increased the inspiratory pressure. If I decrease the inspiratory pressure, you can see he's inflating, but as I decrease it, so right now the inspiratory pressure is 10. And when we set a BiPAP, we usually set one level high, one level a little lower. The first number, so it'll say BiPAP like 12/7, 30%. That'll be what the order says. That means they're going to set the inspiratory pressure at 12 and the expiratory pressure at 7, which means that when you take a breath in and go, it goes and gives you the rest of the breath. And then when you exhale, it holds a little pressure on the end so you don't exhale your whole breath and you keep some air in the lungs. The reason it's not inflating right now is he doesn't really have any chest muscles to help create that breath in. So he's not triggering any breaths on here. But he is getting air in and out. It's just at a level, the inspiratory pressure is 10 and the expiratory pressure is 7. It's not enough of a difference to make ventilation here. You can see his lungs aren't inflating. As soon as I increase the pressure to 20, he starts inflating better. Because all we're doing is pushing air in with more pressure. He doesn't even need his respiratory muscles down. The higher the pressure, the less muscle effort it is. Because look, he doesn't have respiratory muscles. And now he's breathing because we're pushing air in. All it is pushing air in, letting air out. Pushing pressure in, letting it out. If we had the oxygen tank, we would be adding oxygen to the scenario. But you could imagine that he would be breathing better even without extra oxygen. Because look at the ventilation. This is what's happening when he breathes in or out. So I'm gonna actually speed up his rate from 6 to, let's say, 12, because he needs more help. 6 is not enough. He needs to be ventilated at a higher speed. So now we're gonna give him, let's give him a rate of 20. And you can see now that he inflates every few seconds and will probably stay inflated a little better. But I'm going to give him even more pressure. We're going to turn this up to 25. And that's how much bigger those lungs are getting. He has no respiratory effort whatsoever. He's just chilling. He's paralyzed. He could be paralyzed. We are fully ventilating him. We're taking care of him. So the higher the pressures, the less work your muscles have to do. So when your patient is failing, they're failing because their muscles aren't strong enough to really get those lungs expanded. The muscles are weak. The lungs are fine usually. Or there is something in there that is causing a lack of ability to get air in and pushing pressure in. Like if there's fluid in there, or there's pneumonia in there, or there's infiltrates in there, there's something in there, mucus, anything that's in there blocking airflow from your muscles, when we put pressure behind it, it kind of overcomes the problem. So pressure does help. You can imagine that if we put up to a rate of 30 and we're giving him all this pressure, he doesn't really have time to deflate all the way. So you can overventilate a patient if you don't give them time to exhale, just like if you don't give a heart time to empty and it's just constantly doing this, it can't do its job. And if you have a patient hyperventilating at huge volumes, you can see that they don't really get time to exhale. So the ventilator is adjusted by the respiratory therapist. It is monitored by the respiratory therapist. Your job is really to make sure that everything connected stays connected, and that you talk to the therapist if you have any problem, the respiratory therapist. You do not need to manage the ventilator modes or the ventilator settings other than the oxygen usually. We are allowed to kind of titrate up and down on oxygen as needed, but changing the pressures and stuff, that's an order. And I would let the physician and the respiratory therapist manage the pressures and the modes of the ventilator. I do have information on the modes, but I'm not testing you on it because that's not your role really. Your role is just to maintain the system and make sure it's okay. So then I'm going to talk a little bit about the alarms on the ventilator. So I'm kind of hopping around the lecture a little bit. I will go back to the lecture after we take a break. But I'm hopping around a little bit through here because I want to show you what happens to these alarms and what the alarms will do. The first alarm that you will be looking for on this ventilator circuit, if it happens, would be apnea. So let's, for some reason, this patient's breathing independently, which he's not. And then all of a sudden, maybe you give him, Dilaudid, Percocet, fentanyl, you give him a ton of stuff, and he starts dropping his respiratory rate, or he stops breathing altogether. Turn my alarms back off. And you can't see the alarms on here, but if I drop his respiratory rate down, he's not breathing. It's alarming alarm. It's right now, okay, pretend it's alarming. Beep, 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 beep. I shut off the alarm. But it says low minute volume. It's saying apnea and low minute volume. What is that telling you about your patient? He's not breathing. Low minute volume. When you see the words tidal volume and minute volume, that's just tidal volume is how much breath you're moving in and out with each breath. Minute volume is how much air you're moving out over a minute. So it's just whatever your tidal volume is times how many breaths you are. That's how much you're getting per minute. If you're doing 10 breaths per minute at a tidal volume of 400, then your minute volume is 4 liters. You don't need to memorize any of these numbers. I'm just trying to show you that if he is not ventilating adequately, you will probably get a low minute volume or an apnea alarm because they're not ventilating appropriately. I wish these alarms would go off, but maybe they're not that annoying. So I'm going to put him back on his rate. And if your patient was breathing spontaneously and now you're getting apnea alarms on the monitor, on the machine, and you may take care of BiPAP and CPAP on the floors. If your ventilator is reading apnea, take a look at your patient. Okay, your patient is not ventilating for whatever reason. The other alarm you can get, so he's breathing just great now. Look, he's doing great. The other alarm you will get, see if I get it. This one's now reading low pressure. Low pressure. Why is it reading low pressure? There's no resistance anymore. It's pushing air into the room. There's no resistance, and it recognizes that. It's like something happened. You can hear how loud it is because that's how much pressure it's pushing. If you put your hands up against it, there's a lot of pressure. So this is saying apnea and low pressure. It's apnea because there's no respiration, and low pressure because the ventilator is like, what happened to the pressure I was supposed to push against? Low pressure. So when you have a low pressure, shut this off. When you have a low pressure or an apnea alarm, one of the things could be that you're disconnected somewhere in the system. Because if I disconnect any of these things, air escapes and doesn't go into the lungs. Might take a little more force to get this one to alarm, but there is still air escaping. It's going to recognize that the pressure has changed, and it's going to alarm low pressure. So when you are getting that low pressure alarm along with the apnea alarm, it means air is leaking somewhere. It may or may not give you the apnea alarm. This won't give you the apnea alarm. It's just telling me low pressure because it's still sensing breaths. It knows he's breathing, but it just knows that, wait a minute, the pressure that I was pushing in is different now. And that's because air is escaping from the system. So if this is very easy to find where the is, very easy. But then this is a more subtle one. So always when you're getting the low tidal volume or low pressure or apnea alarm, one of the things it could be is you've been disconnected somewhere in here. Any of these can disconnect at any point. And so one of the things, if you see that low pressure or low tidal volume or apnea, check your circuit. Make sure everything's connected, because you can see there's lots of different tubes and connections. They can come apart at any place. Double check it. If you're on high pressure, it will make a noise, and you'll come into the room if you hear this and beeping. So that's one of the alarms, is low pressure, and that means that the ventilator doesn't sense any pressure. Something's become loose in the system. The other thing we'll get is high pressure. So to get a high pressure alarm, let's tink this. So you're not going to hear the alarm, but it is now screaming at me. Well, let me clear the disconnect alarm. But now it's screaming high pressure. Imagine, now it's screaming high pressure. Why is it high pressure? The ventilator's trying to push air, but it's meeting a huge amount of resistance. What is the resistance? The tube is kinked. What else could cause resistance to air getting into the lungs? Now that I fixed the kink, but you could also see when this was kinked and you were getting a high pressure alarm, what was going on with your lungs? They're not ventilating as well because something is blocking that pressure in that air. So a high pressure alarm means something's blocking air from the ventilator. A low pressure alarm means the ventilator is giving air to nothing. And a high pressure alarm means the ventilator can't get past the obstruction. So it could be a kink in the system. It could be, what else could cause an obstruction to air getting into the lungs? What's that? Yeah, you could have too much fluid in those lungs causing a lot of pressure. If the fluid in your lungs goes up, it will cause pressure. You've got resistance to pushing air in if fluid is filling up. So high pressure could be something actually in the lungs. Secretions give you a high pressure alarm a lot, because if they've got a lot of secretions in their trachea, the ventilator can't really push air past huge thick mucus. So you might get that high pressure alarm because you're completely got just too much secretions. They need to be suctioned. So when you have a high pressure alarm, look at your patient. Look at your patient and see if there's something wrong with their actual lungs. You can check the circuit for kinks, but usually high pressure is something in the lungs that is having, if your circuit is okay, the lungs are causing pressure resistance. And you might need to notify the physician or the respiratory therapist. I was getting high pressure alarms. I suctioned them. I turned them. I tried to mobilize things, and it's still reading high pressure. That may be something that they need to come and address, because high pressure, after you've cleared the system, gotten rid of any secretions or anything that should be blocking air, if they're still continuing to alarm high pressure, then the lung is the problem. and the lung is tight and not receiving ventilation very well, which would be a worsening condition. So if you have that high pressure alarm, check the circuit, check the patient, suction your patient, see if that's it. Sometimes patients are coughing and they can still cough. They still have all of their muscles. They still can generate a cough. And so imagine if this is trying to push air in and you do a cough while it's trying to push air in, what alarm are you going to get? You're going while it's trying to push air in, it's going to give you a high pressure alarm. So there's a lot of things that can cause high pressure, and they're usually patient related. Coughing, secretions, anything that's going to increase the pressure in the chest cavity while it's trying to push air into the chest cavity. All those things will cause high pressure alarms. So it's usually patient related, and it's usually an obstruction to ventilation. Try and find that obstruction and get rid of it, because if the ventilator can't get air in and it's telling you that, then your patient's not getting enough air and it's not ventilating appropriately. So any questions on those? Those are probably apnea, low pressure, and high pressure are going to be the alarms that I will ask you questions about on the exam. So I want you to know that low pressure means probably a disconnect. The ventilator is ventilating the room instead of your lungs. And high pressure is it's got an obstruction in the way of ventilation. Those things, and you can go do that at clinical or at TNP if you have a patient on BiPAP, go in and see. If they've got the mask on and it's alarming apnea, your patient may have just taken off their mask, because that's what it's going to say when it's like, I don't feel anything. Well, yeah, if you take off your mask, there's no respiratory triggers. It will also be reading, what's the other alarm that it'll be reading if they took off their mask? Low pressure, because it's ventilating the air. If they are really struggling with their mask on the floor and they're really just coughing a lot and not breathing well and resisting that, then they will be reading high pressure. So with those things, you can kind of go in and maybe check your patient, see if they need suctioning, see if there's something going on with your patient, why they're fighting getting this respiration. Because in a patient in respiratory failure should enjoy being ventilated. I mean, it's not their favorite world, but they will feel relaxed and better on ventilation because they weren't ventilating for so long. Most patients, when you put them on BiPAP or CPAP, are like, oh, thank you. Thank you. That feels so much better. Because if they were struggling to breathe and they were doing this, of course the lungs are going to be much happier when we put air in. So most patients relax to the point where if you have patients on the floor struggling to breathe for days on end, and they're just not ventilating very well for days on end, when we put a breathing tube in and take away the work of breathing, their whole body just collapses. And we've had patients who code when we intubate them. It's not because we did anything wrong. It's because the whole body is finally like, oh, we don't have to work anymore. And the relaxation of all that just sends a signal to the heart to just stop. And so we do have that happen sometimes. And when a patient codes on intubation, it's because they've been working for way too many days and they've used up all their body's energy just trying to survive. And when we take away that extra work, the body just relaxes to the point of really too relaxed. So we have had that happen before, and that's just a sign that the patient's been working way too long. Because working to breathe takes a lot of energy, So the faster we can get a patient away from that heavy work of breathing, the better they do. So early recognition of respiratory failure is real important to save your patient from a further complication down the line. If you can recognize your patients close to respiratory failure or getting there and getting them that pressure support, you might prevent having to do intubation if you can get them BiPAP soon enough to get those lungs inflated so that we don't have to do it manually. Okay. Any questions on that? All right, I'm going to let you take a quick break while I switch out my lungs to my pneumo lungs and give it a pleural sac, and then we're going to give him a pneumothorax. I'm going to show you how the pressures change in your thorax, and then we will put a chest tube in, and I'll show you the chest tubes. So I'm going to just let you guys take what time is it? Let's take a 10-minute break, come back at 5 after. So I'm going to put this back up. And we have now I have these lungs are in a pleural sac. So the lungs that we had before, I didn't have in the pleural sac so that you could see how they blow up and everything. Now I have them in their pleural sac. So this sac is actually usually fluid filled and just kind of sits right around the lungs, okay? It is an actual sac. It's not a Ziploc bag, but you know, hey, it's a pleural sac. So what we're gonna do, these lungs have a pneumo. These lungs broke a while ago. They popped one of their blebs and they have a big pneumo. They don't inflate real well. And so I bought a new set, but then I'm like, I can use these. So what we're gonna do is I'm gonna show you a lung. He's got a bunch of different areas of damaged tissue, just because I've used them for a couple of semesters and blown them up and forgot to put surfactant in them, and he just kind of got used up. So he's got a lot of little, you probably can't see all the little blebs. You're welcome to come up here after and see. He's got lots of little holes and blebs. So what I'm gonna do is I'm gonna put him on the ventilator. He's got holes in his lungs because we've had popped areas of tissue and he's got holes in his lungs. What do you think is gonna happen now when I blow this up? When I start ventilating him?
The bag's not gonna be.
The bag will inflate. The bag will inflate quite a bit. Let's just do it. Nothing better than seeing it with your own eyes. And I can't x-ray your chest and show you what's going on, so this is the best way to do it. I'm gonna start blowing him up with the same air we were giving our other lung, because this guy's in respiratory failure, but he's in respiratory failure because he has a pneumo. And a pneumo, when it goes on long enough, will cause problems. So let's get him going here. I've got him at his inspiratory pressure is 20 and his expiratory pressure is 10. So we've got ventilation, right? But look at the bag. What's happening over here? Yeah, it's going to blow, right? Let's imagine that we've got ribs around here. What do you think is happening to the lungs in here? Is he able to inflate the way he should? No, half the space is just taken by empty air. That's a pneumothorax. You have empty air in your pleural sac. Is this air exchanging oxygen or CO2? No. So what will happen if we keep adding air to this bag?
It's gonna bust.
It's going to do something. And basically, when you're in a thoracic cavity, you got your heart in the front. That pleural sac doesn't even have room to pop. It's in a chest cavity. So it's going to keep growing with air. I think this might have an air leak because otherwise it should have popped by now. But what is happening to the lung as more and more air gets into the bag? More and more air is going to enter this bag. And what's going to happen to the lungs here? You can kind of already see it happening in the back. As this bag fills with air, the lungs have less and less room to expand. Look at this lung here. It's trying to expand, but it can't expand the way it would if we took this bag off. So what we're going to do is we're going to put a chest tube in. So these are chest tubes. I'm going to let him suffer for a little bit because, you know, he's got bad SATs because he's not fully inflating his lungs. Because remember, those lungs were big, right? He doesn't even have half of his lungs really inflating. So his oxygen saturation is going down and his CO2 is going up because he can't expire as much because now space that the lung could fill is being filled with empty air. So we got to get that air out of the sac. And the way we do that is we put in a chest tube. There are a couple of different kinds of chest tubes. They come either in a long thing like this called trocars or just, you know, they're thoracic catheters, whatever you want to call them. They might come in different things. So if you are getting a patient with a chest tube, what you need to do is grab, the physician will tell you what size chest tube. They put it in, but they're going to need you to gather the supplies. So the chest tubes all have markings on them. I don't know if you can see on here. Let's see if I can get it focused. This one is a certain brand, but it says on here, 14 French. This one is on here. This is a 24 French. I don't know if you can see the numbers on the end. I'm trying to show. Let's see. I'm trying to do like a makeup thing. Like, there's my 24 French. I'm gonna put it on in a little. Yeah, no. But anyway, you will get the physician will tell you the size to get. Basically, it's like a Foley catheter. The larger the number, the smaller the size. So just find out what size they want. On this one, it says on the packaging, 20, this is the 24 French packaging. Do you see where it says, oh, I should probably flip my mirror, huh? It's backwards. I don't know how to flip my camera. Oh, well. There it is. Okay. Oh, now you're seeing it for reals. Okay. 24 French. So you see where it says 24 French by 20 inches on the thing underneath quantity. So just look at the packaging for the size. This one will say, this one says 24 French as well on over here. Right behind here. You could tell I am not a YouTuber. I may pretend to be one. Okay, well, anyway. So those are chest tubes. Grab a chest tube, and then you're gonna grab, you get to pick the drainage system. So I'm going to encourage you that if you're picking a drainage system, pick one that says dry suction. Because these are inherently problematic. I'm hoping they don't have these anymore. But anyway, get one that says dry suction, and I'll tell you why. But first of all, we got to get the chest tube in. When you set up this system, there's nothing really to set up except keeping this part. There's a cover on it that keeps it sterile. Keep the sterile cover on it, because you will be handing this off to the physician once he puts the chest tube in, because the tube's going to have to connect to something, just like a Foley, just like anything else. It's going to have to connect to a drainage system. So all you have to do is pull this out of the box, and it has a little water-filled thing, and you put it in here, and you fill up the water seal chamber. That's all the setup on this one. On this one, you fill up the water seal chamber and the suction chamber with water, but don't use that one. All right. What I'm going to do is put in the chest tube. These are some other chest tubes that can be put in. This is a very, very small one, as you can imagine, as compared to this one here. Very small versus very big. The bigger they are, the more drainage they expect. So if they expect a hemothorax or like empyema or something with pus or fluid in that pleural space, they might put in a wider chest tube. If they're expecting stuff to come out of it, like blood or clots or things, you'll get a wide chest tube. If they're just expecting air or think that there's just air, they will use a narrower chest tube or a really itty bitty chest tube. I will show you these different ones in just a second. Let's do this guy. So I am going to put in a chest tube completely, not the way a physician would. I'm just gonna stick it into his pleural space here. I might have to do some maneuvering to get this in. Hang on. How do you set up a patient to put in their chest tube? We got the tube, we got the drain. How do you set up the patient? So they can sit upright, bent over. They can lay on the bed on their side with their arm up. What we want to do is we want to move the ribs, stretch the ribs on the space where they're going to put the chest tube in. So if they say prepare for a right chest tube, what side would you put your patient on? Left side, right side up, arm over the shoulder, okay? So they could be laying down in the bed, right side up. They could be laying back with their shoulder up, or they could be sitting up with going forward. We just want to spread the ribs around there so that they get this in. And they are going to actually physically puncture a hole and stick this in. And it's kind of gruesome to watch. Have you watched one get put in at all? They stick their fingers in there, they pull the hole open, they're shoving this thing in. So it's really not that much different to what I'm doing to Porky right now. It's kind of violent. And there's a reason it hurts. Hang on, let me get this in. Then you can see the magic. Hang on. I have to keep my seal so that this works. Yay, it's preserved for posterity that I can't get this. My fingers are weak. Sorry. I have rheumatoids in my hands. I'm just undoing the seal, putting the chest tube in, and then I will redo the seal. All right, so what we're doing is we're gonna just put this chest tube, I'm gonna call him, if this is my lungs, we're calling this a left pneumo, because it's mostly on the left side. I'm going to put the chest tube in the left space here. So I've got the chest tube in there. I'm going to put my seal back together here. And rubber band seal. So what do you think this chest tube is going to do? You guys, this is just common sense. It's just going to release the air, right? This is just an air release valve is what this is. So we're going to put this little pig back up. We're going to ventilate them again. And what do you expect to happen to those bags when we start ventilating them? We should not see that tension on the bag anymore, right? Where that bag was blowing up before, had a lot of tension on that bag and it was real tight and not letting the lung inflate all the way. We're now put the chest tube in there, and that chest tube is sitting in the pleural space right next to the lung and out, in the pleural space. We've put it right in there, right next to the lung. And once this starts blowing, if we never hooked it up to anything, which I can do because Piggy doesn't care, if I never hooked it up to anything, it would still work. But, and you notice that, you can see my pleural effusion. This is so great. But notice how that bag is not blowing up anymore, right? We got more room. That lung can expand into the bag a little bit better. So that lung will expand a little bit better in here. And there is air. Every time he inhales, air will come out this chest tube, as long as there's no air leak around here. I don't feel the air leak. Okay. So we're already doing a little bit better because every time he inhales and leaks air, it comes out here. The reason we can't leave it like this is what's going to happen if you were using your respiratory muscles and pulled air in, you would suck air in from the room and you would never, it would come out on exhale, but go back in on inhale. So every time he deflates, it sucks air in from the room. So we're not really doing anything. And that's why it doesn't completely empty, because we have not applied any suction to it. And we're just letting air in and out. So we're not doing anything. It's helping, but it's not as good as it could be. So what we're going to do is we're going to put it to the chest tube cylinder. Okay. We're going to hook up this drain to the drainage container. Let's bring this forward. And it might not work completely because where our chest tube's supposed to be, according to your patient. So sitting right next to the patient, they need to be lower. Chest tube should be lower, but for the purposes of demo, I'm going to put him here. Check the bottom of this chest tube. I have not hooked it to suction. It doesn't need to be on suction. It is working. What do you notice when this inflates? Where does the air go now? Do you see where the air is going? Look at the blue water down there. Can you see? I'll bring this a little closer. Ooh, there we go. What's happening in the blue water? It's bubbling. Is it bubbling all the time? When does it bubble? Oops. On inhale, when that lung is real big, it's bubbling out, because when the lung gets big, it pushes air out. This is how the air escapes. This is the water seal chamber. The water seal chamber is where we look for air leaks. Air leak intermittently, which means just on the end insulation, means there's an air leak. Yeah, there is. He has a hole in his lung. Air is leaking out of the lung, but we are letting it drain out and it can't get back in. This bag, this is not perfect. It does have an air leak in it. What am I going to do to suck that air out? We're going to add suction. So all we're doing is, it works just fine like this. This is called a chest tube to water seal. It just means there's no suction, that we are allowing air out and air not to go back in. But it doesn't really pull air out. It just allows air to drain. It would drain better if I put it on the floor. But look at the lung down here. What do you see going on down here? You can see the air leak. This is what happens inside your alveoli when you have fluid in your lungs. That's what's causing the crackles. Imagine that this was a giant alveoli and there was fluid in it. Do you see those bubbles down there? That's what you're hearing when you hear the crackles. If you could feel this, you would feel the crackles at the bottom. I'm going to leave him because I think this is a great view of what's going on in your lungs when your patient is having trouble. So what we're going to do is we're going to hook this up to suction. And then you're going to see that I'm pulling the air out as well as re-inflating the lung. Here, this is kind of passive, but it's not really letting all the air out. It's keeping the thing from blowing up and creating so much pressure that the lung gets compressed and blows up. But I want to get this lung filling the whole bag. I want to get as much ventilation as possible. So I'm going to hook it to suction. And you know how to hook up suction, right? We're going to put it to the suction on the wall. I'm not going to put it to suction on the wall because we don't have suction on the wall. But what we're going to do is we're going to hook it up to the spot that says suction. And I'm going to use my magical, fantastical blackhead extractor to create suction. Sad that a blackhead thing has as much suction as a wall. But now that I've got suction on the system, hopefully it's sucking enough to pull some air out. Let's look at the lungs now. Do you see where the lungs are able to get a little bit bigger now? They're expanding into that bag a little bit better because I am pulling now active air. I'm not pulling real hard because this isn't very strong suction. This is only probably about, it's not even enough to really get the suction's really not working. Because how do I know if the suction's working? How would I know that my suction is working or not working? I hooked the suction up to the wall, but how do I know that it is actually working? I would see a bellows here if it was really working. I had to create suction with my chest because there's not enough suction here. But you will see that when your suction's working, that bellows comes out. Well, the water seal should always, the reason the water seal is leaking all the time, I'm going to get a different chest tube. I don't like this one. This one's got a leak in the system. I'll bring this one back when we talk about that. Let me get one that actually works. You got to see what worked before you see what doesn't work. That one I think broke because I dropped it on the floor. Let's hook this guy up. All right, you go to here. And did you notice what was happening in the lungs while I had the chest tube? It kind of went back to that getting a little bit squished. Let's try this. Well, it was working. Now it's giving me a continuous leak. All right, so what I am looking at here, the reason I'm having a problem is that I know there's something wrong with my system because now when I look at the water seal chamber, what were we supposed to, well, we're seeing it fine just here. What are we seeing at this system when we don't have the suction on? Oop. Are my lungs blowing up? Oh, where's the bubbling? That means no air is getting out. Why is no air getting out? What did I do? Oh,
Yeah.
there it is. Look at that. You just did troubleshooting of the trouble. So basically, when you're looking at this water seal, if your patient has a pneumo, I would expect bubbling in there. I want that air coming out. If my patient has a pneumo and there's no air coming out, that means there's no air leaking from the patient. I know that's not true because I saw a chest x-ray that had a pneumo in it. So if your patient has a pneumo and there's no air coming out, something's blocking the air from coming out. And so once we fix the chest tube here, we see that intermittent. I'm sorry, I keep going the opposite way. So this is a chest tube with a pneumo, intermittent bubbling, okay? But I want to extend this bubbling and put suction on the system. I don't know why my suction is not working here. It's not strong enough to get the bubbling in the system. So this is working properly. You see how it's intermittently bubbling, right? At inhalation. My suction is not working. On the dry one, it showed that the bellow wasn't out. On this one, there's no bubbling in the suction control chamber. So my suction is not working. So I need to put suction on. That might help. Thank you. Thank you for troubleshooting my system for me. Now what do you see? This probably is not set up the right way. There's a leak somewhere. Because it should be bubbling in here, not in there. And you can see that our lungs are not deflating. So I can't get my suction to work. This is open. Okay, that's a lot of suction. I don't know if I'll be able to do that. I guess my thing doesn't have enough suction in it. It did work last semester. Sorry, my comb dome extractor has gotten weak. Well, basically, this is what you would see. If your suction is working on this one, but it will be continuous just in here, okay? This means your suction is working if you have a wet suction. It does not change the function of the water seal. The water seal is for detecting an air leak from the lung. This is for detecting suction from the wall. So if your suction from the wall is an adequate amount, you will see bubbling in here all the time. It's just a suction detection chamber. The other thing about this one is that where are we going to measure this suction at? Let's see if we can get these numbers. This is 5, 10, 15, and 20. What do you think this suction is set to? It's about 15. So this is at 16 centimeters. If the order said 20, what would we have to do? Add more water to the system. If we add more water to the system, it goes up to 20. So these are problematic in that every shift, especially in Arizona, you have to check that the suction is right because these will evaporate, especially while bubbling. These evaporate and you will find out that you're like 5 or 10 centimeters below the actual suction. So in order to get this really suctioning to the ordered 20 centimeters, you would have to fill the thing back up to 20 in order to get the suction. Then when you hook it up to the wall and pull water in, it is actually a real suction. And you can see when I suction, watch the lungs when I suction. That's what we're supposed to see, right? And then if we shut off the suction, what's happening to the bag again? We need, when you have a big pneumothorax, you have to add suction to the system because otherwise passive drainage of air isn't enough to get the air out of the sac, okay? So adding suction to the system, this is a physician's order. They will say, put it at, let's say this is a big pneumo, 20 maybe isn't enough to pull it. Maybe they need 40. If the physician says start the suction at 40 centimeters of suction, can you do it on this one? Is there a 40 marking? 20 is the highest it goes. So if the doctor puts in an order for 30 or 40 centimeters of suction, this is not your drainage system. So I say don't even start with it because it doesn't work and it's not the best system. So we're going to put back on our, this is a broken system and I apologize for that. The suction part is broken, but we can get our catheter going and we can see our air leak in there. Yay. Let's get our suction going. And look at this one. How do you dial the suction? Over here, there's a little dial and you can change the suction amount. Okay. So if he ordered 40 centimeters of suction, all I have to do is change that to 40. There's no water. There's no measuring the level to ensure correct suction. You just dial it to the correct suction in the order. What if the physician orders no suction? What do you do with it? It's just a water seal. All you have to do is just pop the suction off of it. It doesn't matter how it's turned because the bellows isn't on, it's not on suction. But if you did have it on suction when the order says chest tube to water seal, that would be incorrect. It has to have an order for a certain amount of suction to be on the wall to suction. Yes? No, it does not matter what the setting is on the wall. Exactly. And the reason we do this is that the settings on the wall are too high for the lung. If we put it to 40 centimeters of suction on the wall suction regulator is not as detailed as this regulator. This is a better regulator of suction. And when I had a portable suction unit, I would have people come up and feel the difference between suction from the wall at 40 and suction from this at 40. It was actually less because the wall suctions are not dependable. So you always need a chest tube drainage system, one, to regulate suction if it's ordered, and two, to let air out without letting air back in. That's really the purpose of it. Otherwise, it's just a drain. We just have to make sure that the water seal chamber is full and that the suction is correct suction. Okay, those are pretty much the only two things we need to watch on here. When we're looking at the water seal chamber, we are checking the water seal chamber for an air leak. If it's intermittent, that's fine. That means that it's losing air from the lung space, and I expect an intermittent bubbling like this. If he had a smaller air leak, there wouldn't be as many bubbles, but he's got multiple pneumos and he's got really damaged lungs. So I see a real big air leak in that chamber. When I put suction on now, I'm going to put 40 centimeters of suction and stop talking for a minute, but you will see the bellows come out, but there should be no change in the air leak container because we're still losing air. Well, because I'm inhaling so deep. Okay, so that's basically nothing changes. When this lung starts to heal, I can't continue suction on it to, that's what we want. And this is bubbling a lot because we removed a lot of air, right? But as I continue to hold suction, so when I pull it, it continuously bubbles for a minute. But as I pull it and you watch this flatten, you will see it go back to just intermittent suction. Okay, so just watch it for a second. I'll try and hold suction. Okay, so can't do it, but that's what I'm trying to do is show you that a continuous leak down here means either you're pulling a ton of air out of that chest, because when I pull all the air out of that chest, it's going to pull. Let me see if I hold the air out of the chest. So I'm going to suction it all out and then hold it. But look what happens when it's basically not under suction anymore. Watch the air fill it back up. That's why we have to continue to stay on suction to keep pulling the air out. He's got a huge pneumothorax. Huge pneumothoraxes are going to have larger air leaks. Okay, but they should be intermittent like this. Okay, intermittent water bubbling in the water seal chamber is okay when you have a pneumo. It's an expected finding with a pneumothorax. What if you put this in for a pleural effusion down here, and you can see how this is not draining fluid because it's up high. If I wanted to drain fluid, I'd have to put the chest tube down low and let it drain. This one's never going to get the fluid because one, it's not on the right side of the fluid, and two, it's not low enough to capture the fluid because the fluid is going to be dependent. So if we're going to be a fluid draining this pleural effusion down here, I would need another chest tube on the other side lower. And you can put in 2, 3, 4 chest tubes. They have had chest tubes. I've had patients with 3 chest tubes in. Each chest tube can go to its own drainage system, or they have these little Y connectors, just like a Y site on your IV. They have these little Y connectors here. They just look like little Ys, and you can actually hook multiple chest tubes together. So if I had another chest tube coming out, I could put them to the same drainage container. Okay. So there's lots of different ways you can hook up chest tubes, but this is basically the basic part. And I just wanted to show you why we're doing it. It doesn't make much sense until you see what's happening in the lung itself, why we're doing it. And so this poor piggy has such a big thing that I really cannot inflate his lungs fully unless I suction the air out. And now he could fill the whole sac once I suction the air out. Okay, so that's basically what we're looking for. When you're looking at the chest tube drainage system, check it first for proper ordered suction. Look at your suction chamber. Make sure it's just in the right thing. If it's on this, make sure it is to the right level, okay? Then when you hook it up to suction, on the dry one, you'll see a bellows come out. That means your suction is adequate. On the wet one, you will see continuous bubbling in the suction chamber. Those are the two indicators that your suction is working. And you can see that my suction is not working right now because there's no bellows, and I had to pull really hard to get suction out of this guy. So we're checking the suction for order and functioning. Then we move down and look at the water seal chamber. If this was draining out a chest tube that did not have an air leak and it was just draining fluid, what do we see in the water seal chamber? Nothing. That means no air is coming out of the lung. You may have drainage out of the lung, but there's no air. So that's a good thing. If you had a chest tube that's looked like this and now looks like this, what have you developed? You had a water seal that wasn't bubbling at all, and now your water seal is bubbling. What happened to your patient? They got a pneumo. Maybe because of the ventilation, maybe because they had surgery. But if you had a water seal chamber that was still, and now it's intermittently bubbling, your patient developed a pneumo. That is a new finding. You would have to notify of it, okay? You notify of new pneumos. It's not like you're going to do anything because the chest tube's already in place, but they would want to know what was going on with the lungs, that they popped a pneumo basically in the middle of their, whatever they were draining. Maybe they were draining out a hemothorax. If you had a trauma patient, they put in the chest tube to drain out bleeding, and you looked at your water seal chamber, it was draining blood, you're draining blood into the drainage, and your water seal chamber was still. That would mean you just got all the fluid out, all the hemothorax out, but the water seal is not leak. There's no leak. There's no air. There's no damage to the lung. You just drained the blood, but there's no damage to the lung. There's no pneumothorax. If you've been sitting like that for a shift or two, and now it intermittently bubbles, it was still, and now it's intermittently bubbling, maybe that patient moved and popped something, or maybe a broken rib got in there and popped something. It's still a new finding, and we need to know about it. The treatment is in place for a pneumo. You're not going to have to do anything new, but what do you think you would order if you told your doc, when I got here, the water seal chamber wasn't bubbling, and now it's intermittently bubbling? What do you think he's going to order? A chest x-ray. Let's see where the hole is. The other nice thing about it is if Torquay here started healing and started repairing his lung tissue, what would we see happen in this water seal chamber? If he started healing and clotting over these holes and healing these holes, this intermittent air leak would get smaller and smaller and smaller. And that tells your patient, that tells everyone your patient is healing. This was a huge air leak, huge amount of bubbles every time he took a breath. And then as he heals, that will get smaller and smaller and smaller. And then when that water seal chamber is still again, that means all your holes closed up. So we can monitor the patient for healing with a chest tube as well. Once they don't have any air leak in the water seal chamber and their drainage has slowed down, then it could be time to pull the chest tube for whatever reason. If we put in this chest tube for a hemothorax, they will leave it in until the hemothorax stops draining. And they're sure it's not going to start again. So you might leave a chest tube in for like a week to just double check that it doesn't start bleeding again. Because if we put in the chest tube for a hemothorax, what would we expect in here?
Blood.
I would expect blood in the drainage chamber because we emptied the blood out of here. And then I would expect no air leak because we didn't have a hole in the lung if we just had a hemothorax. So I would expect blood, no air leaking, and my suction at the right thing. What if we had a pleural effusion? What if I put in the chest tube to drain this fluid here? A pleural effusion, what would we see in here? What would we expect to see? Clear, straw colored, this colored drainage, basically, this little yellowish drainage. That's what I would expect to see in here because we're draining a pleural effusion. Yellow straw colored drainage, maybe a little pink, serosanguinous. What if it started becoming frank bloody? What's happening in your lung space? It started bleeding. That's a new finding. So if you expect blood in there because you're draining a hemo or a wound, okay. But if it changes, notify your physician. If we saw blood in here and then it changes over to yellow straw fluid, what does that mean? It means that your patient has stopped bleeding, but the repair stuff is all in there cleaning up. Yeah, that yellow clear fluid is inflammatory fluid. But we expect that as they're cleaning up and healing. So that is a healing sign. If you are frank blood transitioning to serosanguinous, that's healing, just like it is from a wound. You want the serosanguinous, that's fine. And then as that drainage slows down, that's a sign of healing and the immune fluid is going away. So we are not only putting this in to treat the problem, but also to monitor our healing of the problem. So we're watching for changes in drainage, we're watching in changes of air. If you start out with a patient with a pneumothorax, I expect to see bubbling in there because we're moving air from the system. But if they have not had one and develop bubbling in there, that's a new pneumo. Just let the doctor know so that they can assess what's going on with the patient. And that's about it. I think that's it for the chest tube. If the chest tube is broken, so if this one, it turns out it's not broken. If it was broken, as I had it set up like this, sometimes you push patients into the elevator with their chest tubes on the end of the bed. We shove them in there. They're plastic. They can crack. What would happen if we got a crack in the system? Let me just crack the system here. I'm cracking this. Oh, this isn't. Let's see. Let's give him. I want to get on the tiny hairline crack. Tiny hairline area. Okay. What do we see now in the system here? Oh, am I going to simulate a system leak? It's not doing it. Well, if we had a system leak, my systems are working. If we had a system leak, this would be continuously bubbling because water is continuously entering the system. We don't want continuous bubbling in the water seal chamber ever. The water seal chamber has three things. Still means no air leak from the lung. Intermittent means lung has a pneumo. And continuous means your system is broken and you have a problem with your system. I'm trying to stimulate a problem with the system, but trying to give you continuous. Here, let me try this. This is what continuous bubbling looks at. So keep an eye on the water seal chamber down here. That's intermittent because it's just happening at the very end of the breath. Here's continuous. Come on. That's continuous bubbling. We don't expect continuous bubbling in the water seal chamber. The water seal chamber should be still or intermittent only. If you see continuous bubbling in this water seal chamber, you have to change out the drainage system. There's something wrong. Also, it is supposed to continuously bubble if your system is open to air and on suction. Let's see. A disconnect will cause continuous bubbling. Do you see that continuous bubbling in there? That's because we disconnected it and suction is pulling air from the air. That's not intermittent, that's continuous. So if you see a continuous bubbling in the water seal chamber, fix your system. Something's wrong. Check from the patient all the way down through the system. Something's wrong with your system. Does that make sense? So really, your water seal chamber is your diagnostic chamber of what's going on in your chest. This is just what's coming out of your chest. We would check and see what's going on with our patient to see what we should be seeing coming out of our chest. This is for air leak detection or system breakage. Still, that's great. It just means you don't have a pneumo. Intermittent means you have a pneumo. And continuous means there's a leak in the system somewhere. Okay? And then the suction control chamber, just check that it's at the right level and that the bellows is working. Okay? The thing that gets people on the test is that continuous bubbling because it's not normal unless you're using this crappy system. If you're using this crappy old system, this is normal over here, not in the water seal chamber. It's never normal to have continuous bubbling in the water seal chamber. The water seal chamber is your air leak from the lung detection system. Okay? So I think that's all I have to say about the test tubes. There will be questions on the test about chest tubes, probably about 4 or 5. I will give you pictures of the chest tube to remind you of what they look like. But I want you to really remember, check the water seal system. That's where we look for air leaks and whether our system is functioning or not. The suction control, only worry about if you have an order for suction. Okay, you don't have an order for suction, what is that called? What's that order called? If they want you to not be on suction, what do they write it? Chest tube to water seal. That just means no suction. That means your chest tube is sitting, the water seal chamber is intact, but there's no suction in the system. Okay, water seal just means air can't get back into the lung space, but it may not efficiently drain without suction. So any questions on that? When you're listening to your patient with a pneumo, what do you expect to hear when you put your stethoscope up against this? You're not going to hear anything because this system, you can hear air coming in and out because he's got a huge pneumo. But normally you are listening to the sounds in the alveoli of air coming into the alveoli, air exiting the alveoli. But when you're putting your stethoscope up against a place where air is not exchanging, you will not hear noise. It will be absent, or you might want to call it diminished. Diminished and absent, it's hard to tell the difference between them. So you can put diminished or absent, but really they're going to lead you to a chest x-ray. Anytime you have diminished or absent breath sounds, we need to double check why and see why. Does everybody kind of understand chest tubes a little better now, hopefully? Fingers crossed? Yes.
Are infections really common in chest tubes?
They can be. They can be because think about this. This is going, I'm going to take this out for a minute and shut them on. This is going into our chest space. So yeah, because it's not going straight into the bloodstream, they won't be bloodstream infections, but they would be infections in the pleural space, which would increase your inflammatory drainage. It would keep your pleural effusion going and going and going. And especially if the drainage coming out of here was cloudy. But yeah, because this is going straight into my thoracic space, what do you think the dressing is going to be on this? What dressing would I put to my, sorry, if you're watching the video, and what dressing are we putting where it enters my skin? I want something that is occlusive to the skin. So we're going to use Vaseline dressing around the tube where the tube meets the skin. Vaseline dressing, it's just to keep, any extra air from getting into the system. And also you could do whatever the doctor orders for it. But usually the generic, if there's no order for a certain kind of dressing, we will wrap Vaseline gauze or put Vaseline gauze where it meets the skin, so that we keep air from expelling or expanding out of that space, and then just cover it with a sterile dressing. Okay. So the dressing on here, Vaseline gauze with a sterile dressing over the top, and then tape it all down. A lot of nurses will tape it. If I'm taping it, they're going to put a dressing here where it meets the skin and comes out of the skin. Vaseline gauze and a sterile dressing. A lot of times they will tape down here as well, because you don't want the only pull site to be right at your chest. So just like a Foley, we're going to secure it a little further down so that if they pull, it pulls at that tape down here, not at the actual chest tube. You're also going to make sure that these sections are taped because these come apart pretty easily. So tape up any connections as well. One, to keep air from getting into the system, because if this popped open a whiff right here, you could get air into the system and it wouldn't be suctioning properly. So just make sure that everything is tight and taped at any place where they could come apart. So they have a dressing and then all their connections are taped and tight. That should keep your chest tube fine. If your chest tube becomes disconnected, so let's talk about all the problems with chest tubes. You got a tube coming out. What happens if it becomes disconnected here and this falls on the floor? Well, yeah, that you can't put it back together. This fell on the floor. That's on the floor. What are you going to do with this chest tube? Because every time he breathes in or breathes out, air is going to get sucked into the chest cavity. Put it in sterile water, because then you make a water seal. Because air, if you put this in sterile water, this is not sterile water, but boop, I'm just going to drop it into a cup of sterile water. When they exhale, what's going to happen in the water? Or when they inhale, bubble, 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 bubble. And then when they exhale, water can't get back in. So just drop it in. You're making a water seal. This is a water seal. That's a chest tube to water seal right there. That's an emergency placement until you can get a new clean setup. So just get a urine cup full of sterile water, dump it on, just put the thing in there and then have someone set up a new chest tube drainage system for you. And as soon as you get the new chest tube drainage system, all you have to do is make sure that the cover stays on here and it's sterile, and then you can reconnect your thing to a new drainage system. Yes?
Well, it's like the mouth of the whatever.
No, you don't, because the water is the leak sealer. You don't have to worry about covering it or making sure it's airtight right here, because air will escape out into the water and bubble out, but water cannot get in from the atmosphere into the tube. The water makes the seal. So you don't have to worry about sealing up the outside. No. Good question though. So emergency treatment, if it comes disconnected and this is dirty, drop it in some water. That will keep air from entering the chest and keep your water seal until you can get a system with a water seal back on it. What happens? So that's if it comes disconnected within the system. Just drop it in water if the chest tube's intact. What if the chest tube has pulled out? What do you have left in your chest? If the chest tube pulls out, you have a hole in your chest. So what's going to happen from that hole in the chest? Air is going to get in. So what are we going to put on your chest? Well, we're not putting that chest tube back in. Even if it pulled out, not all the way, but it's out so that it's not working, we're going to just put a dressing on there, a 3-sided dressing. The 3-sided dressing is only for an open hole in the chest. So a 3-sided dressing only for an open hole in the chest. If you are dressing a regular wound, it's just a regular wound dressing, all 4 sides. The 3-sided tape is for, so you're going to basically put an occlusive dressing, not a tegaderm though, because you can't, tegaderms will seal all the way around. You don't want to put a tegaderm on it. You want to put just probably a Vaseline gauze dressing or something that has some occlusive properties to it. I don't care if it's Xeroform or something with some kind of cream on it that you can throw over there. It could be silver. I don't know. Just get an emergency thing, something with some kind of cream on it. Any gauze with cream on it, Vaseline, Xeroform, anything with cream on it. Throw that on there and then tape, put a regular piece of gauze over it, tape it on 3 sides. What's going to happen when they inhale full air? Where's the air going to go? Out of the hole of the chest. It's going to pop out. And so because you have a space for that air to go out of your chest, it will escape. But then what happens when the pressure in the cavity gets higher? When you exhale, it sucks up against the chest and doesn't let air in. So that dressing flops open when air needs to get out and pulls in when you don't want air in. So it creates not a water seal, but just a seal. So if your chest tube becomes disconnected, give it a water seal until you can get a new drainage chamber. If the whole chest tube comes out, leaving a hole in the chest, that's where you have a 3-sided dressing. Okay. And that will also work if you work in an ER and someone comes in with a gunshot wound or some kind of sucking chest wound, which means that they're pulling air in from outside. 3-sided dressing is appropriate for any hole in the chest. Okay. So you can do a 3-sided dressing, but that is just for a hole in the chest. If you are talking about a disconnected chest tube, that goes into water seal. Okay. Questions? The connection thing here is for if the chest tube stayed sealed and connected from here down to here, but this drainage chamber got full, maybe you're draining a big hemothorax or something, and the drainage chamber became full, how do we allow more drainage? Do we dump it? We don't dump chest tubes. They're not Foley's. We don't dump them. All you have to do then at that point is get a new drainage system. As long as your drainage system has stayed connected and is still clean, all you would have to do is get a new drainage system. You could take off the hose that it comes with, get the new fresh sterile system and reconnect it. But you would have to keep the ends sterile and clean. We don't want anything dirty because yes, it is a chest right into your chest cavity. Germs will crawl up and get in there. Yeah. If you need to culture test tube drainage, from this system is like a Foley. So what you would do is probably just get some in your tubing, let it kind of sit in your tubing there, or let it drain into the tubing and kind of just keep it like that so that you get enough of a sample. And then you're going to clean this surface, hook up a syringe to it, and then you can pull that stuff out of the system. These are also silicone. They should be self-sealing. So if you really needed to, you could do a fine needle puncture and pull tubing out of there, and it should self-seal again. But I haven't ever done that. Usually we would access through there. That's a great question. No, you can culture chest tube drainage to it. And again, if this chest tube's been in a week or two, yeah, you might as well pull it out from there, because I want to know what's in this chest tube system. So if people come in with chest tubes, yes, we do culture the drainage. That's a great question. You would get it out of the port right here. Again, another reason why this one sucks. All you need to take away from this is never get a wet system. One, they limit you on your suction. And two, all of those nice connection systems and everything don't exist on here. So you have to change out the whole system, the whole tubing each time. And if you wanted a sample from this, yeah, you would have to puncture through it to get the sample. So again, the moral of the story, don't use the wet ones, but they might still ask you about them on exams because they still exist. And this is the one that confuses nursing students. The only time continuous bubbling is okay is in the suction control chamber of a wet system. Otherwise, in this system, there's never should be any continuous bubbling, okay? Continuous bubbling is only okay in a wet system. So if you get a picture of a wet system, and the question says continuous bubbling in the water seal chamber, is that okay? No, there should never, ever be continuous bubbling in the water seal chambers. And the water seal chambers are the little guys at the bottom there. When I go through this PowerPoint, I'm just going to go through real quick. Slides 4 through 11, you don't need to study. Okay, 4 through 11, you can just ditch. Those are there for your NCLEX studying or review from block 2 if you feel like you need review from block 2. That's what slides 4 through 11 are. So this is just to remember how the capillaries and alveoli work. I will outline this on the PowerPoint. I'll explain a little bit more about all these slides in the long version. This is the review part. These are all airway disorders, which mean you have a problem in your airway. These are blood vessel disorders. This is a disorder around your lungs. This is all review, not on your test, because it should be review. But if you don't have it, this is a place for you to get it. This is just basically if you have any of the airway diseases, alveoli diseases, blood vessel diseases, you should have covered those already. Alveolar membrane disease is where we're going to start. You might have heard about pulmonary fibrosis and sarcoidosis. These are things that damage the layers between the alveoli. And so when I'm talking about damage to the alveolar membrane, we are talking about damage to these two cell layers right here. The cell layer on the outside, the cell layer on the outside of the alveoli and the cell layer on the outside of the blood vessel. These two are where gases cross. And when you have pulmonary membrane disorders, you either have scarring or damage along these membranes, which instead of allowing just gases to cross, allows fluid and blood to cross, or they are scarred and thick and tight, and they do not allow gases to cross either. So when we're talking about the alveolar membrane, we're talking about the outside of the alveoli and the inside of the blood vessel there. And our first disorder is respiratory distress syndrome. I will go over this more and more, but imagine that's a healthy alveoli on the right and then an unhealthy ARDS alveoli on the, oh, sorry, the right is unhealthy, the left, or at least on my side. This side is healthy, this side is not. But what is happening basically in ARDS is that the blood vessel and the alveolar membrane are both becoming damaged. This is an autoimmune response. This is wrong breaking of the alveolar membrane. This is what kills people during COVID, is ARDS, not the COVID virus. The COVID virus, for some reason, sets off ARDS, or adult respiratory distress syndrome, which means that bilaterally, normally if I hurt little piggy over here on the right lower lobe, yes, this is right lower lobe, then we will have inflammatory stuff in the alveoli around that damage. We will have localized inflammation. If you have a pneumonia or damage in the right lower lobe, I expect to see right lower lobe inflammation or damage because we have a problem going on there and the immune system's trying to fix it. When it becomes bilateral, it's either heart failure or respiratory problem. But when we have bilateral crackles, we talked about with heart failure, that's the heart's fault. But here we've ruled out the heart as a problem, but we still have bilateral crackles. And that means that the immune system has attacked the lungs and is damaging the lining between the capillaries and the alveoli. And that damage causes fluid to be able to get across the membrane and the oxygen does not transfer. So ARDS is an autoimmune response to any serious illness. It could be COVID, it could be pneumonia, it could be sepsis, it could be lung trauma, it could be any serious big problem that sets off this autoimmune. If they could figure out what sets off ARDS, they would prevent a lot of deaths from lung disease after illnesses. But a lot of patients with sepsis will end up with ARDS. A lot of patients with COVID and pneumonia, some of them end up with ARDS. We used to just have regular flus that would send people into ARDS. We don't know enough about how ARDS is stimulated in order to, and believe me, the research after COVID is going to take off because there was no telling. You could get COVID and have nothing. Some people can have COVID and have a sniffle. Some people could get COVID and die of ARDS. This is why people were getting prone and why people were on ventilators and the ventilators were not working because the lungs were too damaged. We couldn't do anything about them. We could do our best, but then they found that positive pressure and ventilating people was causing these lungs that were damaged to blow. And they were causing more damage with ventilating. So they stopped kind of going to ventilation first and started doing other things to help the lungs first. So when we're talking about ARDS, I want you to remember this is an autoimmune response. It happens bilaterally, causes damage to the capillary membrane and the alveoli, and they become damaged, stiff, they don't exchange gases, and they do leak fluid very easily. So fluid is leaking from the bloodstream into the lung space bilaterally, starts out with fine crackles. Where do you hear crackles? If we're listening to pig, where are we going to listen to them? We're going to listen to the back posterior at the bottom because fluid drops, right? With gravity and your lungs are hanging here. Any fluid in your alveoli space is going to drop to the bottom of the lungs. So we're going to be listening on the bottom. When do you listen? Inspiration or expiration? Inspiration. When these lungs are full of air, then we can try to hear that air get pushed through the fluid and that makes the crackle sound. On the video, I will actually have a sound back and forth. I have a YouTube link to listen to crackles, but they will be fine and early. So I will tell you that you will miss ARDS early signs. Everyone does. It's okay. But you do need to know the earliest signs of ARDS and why. Why bilateral fine crackles? Fluid is escaping into our lungs due to the damaged alveoli, but it's all dropping to the bottom because the patients are usually upright when they don't breathe well. So the fluid is in the bases of the lungs. As this continues to dump fluid and decrease oxygenation, there will be more and more and more fluid in these lungs, right? And you will start to hear the crackles get louder and they will move up bilaterally through all the lobes. By the time someone is completely whited out, which is these two chest x-rays here, that's a normal chest x-ray. I do have very basic, you're not gonna have to read any x-rays on the test. But when you're looking at a chest x-ray, if you do get a chance to look, black means air, white means fluid or bones, and spider looking means fluid in some small vessels. So you are not seeing all the alveoli and all the capillaries because they're microscopic. 1 cell thick, you can't see that with your naked eye. It doesn't show up on the chest x-ray. But these areas over here, these little spider web looking things, those are your pulmonary artery and pulmonary veins. They are bigger vessels and they are fluid filled, So we start seeing some pulmonary vasculature until it gets too small to see. So we normally see, this is your heart right here. This is the silhouette of the heart. These spider webs on either side are your larger pulmonary artery veins going away, and then it turns into capillaries, which are so microscopic, we don't really see them. So we just see the air that's surrounding. But what is happening on this lower film? What is happening on this lower film is you're seeing so many spider webs. Now you're seeing the capillaries, because the capillaries and the alveoli are full of fluid. This lung has gotten white because there is fluid all throughout it. It's in the alveoli, it's in the extrapleural space, it's in the blood vessels. So we are seeing more fluid on our chest x-ray. And that's what's called whited out, because white means fluid. It's not new bones that grew there, so it's fluid. And that's what a bilateral whiteout looks like, and that's what patients with ARDS will look like towards the end. What do you think they would look like when they are first developing ARDS? They would just be white at the bottoms. And they call this a ground glass because it looks kind of like if you crack a windshield, you know how there's like all those little circles of glass on your windshield if you crack a window or something on your car with safety glass. That is those little, you start seeing the little alveoli. You start seeing like those little pock marks. Those are fluid-filled alveoli. We normally don't see them in the normal x-ray because it's just air in there. But then as fluid fills them, you start seeing fluid on your chest x-ray. So you won't see really much, except if you get a chest x-ray, you will see bilateral infiltrates, which means that fluid is infiltrating the alveoli. And so you will start to see white in the bases, and then as it worsens, they get fluid all the way up their lungs. So at the beginning, why do you have tachypnea, meaning increased respiratory rate? We're going to stop soon, and you're going to go, and you don't need a lunch because we're going to get out of here in the next half hour. But you get tachypnea because you're not getting enough oxygen. Your lungs are getting full of fluid, oxygen is not exchanging, and so your body tells you to breathe faster. Tachycardia, because you're not getting enough oxygen, the body's like, hurry, get more, circulate this oxygen around, even though there isn't that much. So you get tachypnic and tachycardic trying to get more oxygen around to your body. The fine crackles is what you hear with your stethoscope, and you would see bilateral infiltrates on the chest x-ray. A lot of people miss this because they've got other things going on. They've got a severe illness, a bad pneumonia, a sepsis. We're not that worried about it. We miss it because you'll see tachypnea and tachycardia with almost everything. So it's hard to rule out. But then you get your oxygenation does not get better with oxygen or increasing support. So you got a nasal cannula. Here we are with this little lung. He's filling up with fluid. And we're like, here, have some nasal cannula. That's getting oxygen to the top parts of the lungs, but we're not doing anything with the bottom parts of the lungs. So you keep giving them more oxygen, more oxygen. It's not helping your oxygen status because no matter how much oxygen we're throwing in there, they're still only ventilating maybe half their lungs. And so we keep throwing oxygen at them and their oxygen level doesn't get better. And that is a sign that something's wrong. You start hearing more and more crackles. That is, ooh, we might have ARDS going on, get a chest x-ray. And when you see the chest x-ray with whiteout, they say they do have ARDS. Respiratory failure is going to be your worsening condition of every single respiratory condition. Every single condition, when it's worsening, is respiratory failure. So respiratory failure, we're going to talk about the worsening condition. But this is what we do for people that are having trouble breathing or have fluid in their lungs. And why is that? I'm going to get this little bit. Bring it over. This, oh, you're good. This is your lungs. This is the front of your lungs, and the back of your lungs are just, the backs is pure lungs, right? Got a lot of lung space along the back. What's in the front? Your lungs are actually kind of small in the front. They're like a little triangle, whereas they're a huge rectangle in the back. So we got a little triangle in the front, big rectangle in the back. We also have a heart, and we have a lot of vessels returning to the heart. And so when we lay on our back, what's pressing on our lungs? The heart and the blood vessels. Everything presses when we're laying down. So we sit the patient upright. That helps. It drops fluid down here and aerates. But look at the aeratable part of the lung is a tiny triangle. When we lay someone upside down, what happens to their heart and their blood vessels? It hangs. It hangs away from the lungs, right? Kind of hangs And look where the air can rise. Air rises, fluid falls. Fluid will fall to the smaller part of the lungs. Fluid goes down gravity to the smaller part of the lungs, and you have air going to the big part of your lungs in the back. So you actually use more of your lung space aerating laying prone, which is face down. Whereas if you're sitting upright, where is the air going? To the top tips of your lungs, which are not nearly as big. So as soon as we prone patients, they start breathing better because air rises to the bigger part of the lungs. So that's why we like proning people. It's just anatomical. There's not as much room when you're like this, lots of weight, and all the air is rising to the small part of the lungs and the fluid's going to the big part of the lungs. So if we upside down, fluid goes to the small part of the lungs, air goes to the big part of the lungs. Proning is a great intervention for anybody in respiratory distress that can handle it. Some patients, if they are too short of breath, don't want to do this. It doesn't feel good. They don't sleep on their stomachs. It makes them uncomfortable. Then we won't do it. But it should work because of anatomy. The bigger parts of the lungs are on the back side of our back. Air rises, fluid falls. And so that's why we prone people. So it is an intervention, not just for ARDS. It is an intervention for any respiratory distress, but a lot of people can't tolerate laying on their bellies for whatever reason. So we will try it as an option. And now it is becoming, it used to be a last resort to prone people. Now it is becoming a first resort. COVID taught us that. COVID taught us, don't save it till the end. Flip people sooner rather than later, because it's good for them to have more air to the bigger parts of their lungs. So proning has become a much more frequent and early intervention for any lung disorder, but it's really if your patient can handle it. Otherwise, when they go into respiratory failure, we might force it, but it's generally an option. So with ARDS, we will give them medications. Anytime fluid is in the lung, you have a chance of infection. Bacteria get in there and they're bathing in your wonderful plasma that's full of glucose and nutrients. So we always have a risk of infection. Know how they recognize the difference between pneumo, hemo, and pleural effusions, mostly for application on questions like your patient got a chest tube for pneumothorax. It's just like, you shouldn't be pulling blood out if you have a pneumothorax. If you have a hemothorax, it's okay. So know the differences between them. But you notice that expected or the regular having them, yeah, this is expected. Breath sounds diminished, that's expected. Shortness of breath with exertion, eating is considered exertion, so that's expected. Tachypnea, tachycardia. This just means you might have a pneumo, but I'm not too worried about it. This means I'm worried about it, okay? They may do an intervention here, they may wait for here. I don't know, I'm not the doctor. They can intervene either one. But I would do nursing interventions here, but they might not do the chest tube until you get to this point, okay? Asymmetrical chest expansion, that means that there's so much fluid, air, or whatever in here that the lungs can't expand, and that will give you that asymmetrical chest because only one side of your lungs is expanding, the other side's filled with junk. So asymmetrical chest expansion, shortness of breath at rest, which means they're just sitting in the chair and they can't even talk to you. And then of course, these are very, very late. Decreased blood pressure is because all this squishing out of place actually squishes your heart and your aorta and your vena cava and your blood circulation. Tracheal deviation means it's already moved over to the side to the point that you've actually deviated your trachea, so it doesn't sit mainline. It like the trachea is at a diagonal on your neck. That's a sign that your chest is not. You'll probably have these two together. And respiratory failure is the worsening condition of all of our respiratory cues. We let them go, but once they start showing signs of respiratory failure, we have to intervene. I'm not testing you. You're not going to have to read chest x-rays. This is just for your information. The interventions, again, this is just, hey, monitor oxygen if you need it. And then if it gets to the point where they're worsening or in respiratory failure, we will have to remove the fluid. And they can do it two ways, with just a needle and a one-time removal, or putting in the chest tube for a continuous removal. Bronchoscopy, again, these are just when they're procedures. I want you to know mostly what's expected and not expected post procedure. Okay, so as you go through these, when you're doing these, I really just want you to know The questions will probably be, when do you call the physician, or your post-op, what's worrying you? I don't want you to worry about things that are expected. Don't call the physician for things that are expected. And that's kind of a great way to go back when you're studying for the NCLEX. Go back through your old notes and try to separate the cues into expected and not expected, because those will give you the information when you need to notify the provider. You notify them when something not expected is happening. So as you clean up your notes from walk 1, 2, and 3, try to divide those things up when you have a problem or a procedure. Thoracentesis, just because of where we're sticking a needle, if you highlight, and I will, again, do my drawings and everything as I'm going through, expected pre and post, but the reason complications are pneumo-hemo, look where you're putting the needle. They're trying to fit it into that tiny little pleural fluid space, this tiny space here. I'm trying to get a needle into that little section. Boom. If I go any higher, I'm in lung. I go any lower, I'm in liver. There's not a lot of space in there. So there is a high risk that they could stick the wrong place. We got to watch for that. Okay. And that's a notification. If you went in to remove pleural fluid or hemo fluid or even air, and now you're having something different draining out, something different happened, and you need to let them know. If they went in with a needle to drain out fluid and they are now having symptoms of a pneumo or a hemo, they probably are having a pneumo or hemo. What are you going to call for? A chest x-ray. We don't know what's going on. They're going to get chest x-rays for everything, but you have to notify the provider if you have them to get those orders. Chest tube, again, because that's a procedure, I split it up into, you might need to know how to position the patient. And that's what we talked about, the positioning. You might also, this is just for your own information. I'm not testing you on the differences between the systems. This is for your own information about the different kinds of systems that are out there. I do have a couple of those self-contained systems. This is a Heimlich valve. It's shown on that patient there. And the other one is a Urocele. You don't need to know the names. I just have them here in case you want to look at them. Where'd the Urocele go? Dude, I had you. Did you fall on the floor? Yeah, he did. Oh, he's disgusting and dirty now. We can't use him. This is the Urocele. Again, when would they put these guys in, do you think? These don't hold a lot of drainage. These are for continuous pleural. If you are like, when patients have cancer, they keep getting inflammatory fluid in their lungs if they have lung cancer. Sometimes these patients get drainage just because they're constantly going to have pleural effusions. And so they will get these. Or if you have lung cancer or long-term lung damage, you might constantly be getting pneumothoraces. And so they might just put these in. These are more long-term, go home with chest tubes. This one will attach to a regular chest tube. You can see it in his chest there. It will attach to a regular chest tube, probably a small sized one. But this one can attach to a regular chest tube. What's the difference between this and a regular? This is a drainage system similar to this. This is considered a drainage system. What is the difference? Definitely volume. It can't hold much. So this is great for pulling air, but not a lot for pulling hemo or pleural effusion fluid because it doesn't hold much. The other difference is there's no water seal chamber in these guys. These don't have a water seal chamber, so you can't do air leak detection. How you know if they're working, let me just flip to the camera real quick. Stop there. Go back to my camera. So these guys are the two chest tubes. This is a one piece where they actually will insert it in interventional radiology or at the bedside. This is the actual chest tube instead of having a big fat guy that you get out of the storage room. It comes with its own little one. And they will just put that in where it needs to go, up high, up low, and then they just fasten it to the chest. How you know it's working is when they breathe in and out, you will see this one-way valve right here, open and close. And basically what it does is this is a piece of plastic that when the pressure in your cavity gets low because your lungs basically shrunk and suck air in, instead of sucking air in, this one-way valve will suck shut so that air can't get into the chest. And then when you breathe in and you want to push air out, that valve opens up and allows air out. And then it's ventilated in here so the air can get out of the system. Okay. The nice thing about both of these is if your chest tube starts having a lot of drainage, maybe they popped a they got a lot of pleural effusion and is filling this up. You can take this, the uroseals have their own, so patients might come into the hospital with these guys and need to have them hooked up to suction or to drainage. Uroseals, they have a drainage kit that's usually in your supply room, that if they come in with one of these, you can go ahead and change this to a regular chest tube and hook it up to suction or whatever you need to do with it. You can hook it up to a regular drainage system on top of it. Okay, so that's why a lot of our patients will come in, maybe they have a home chest tube, but they started bleeding or they have more complications, and they may say, and this is what got called the CRTs, where they're like, we can't hook up the chest tube. And I'm like, oh, you have to get the uroseal connection kit. So there may be people where you're going to need to ask, like, I don't really know what to do with this. I'm supposed to hook it up to suction, but what do I do? And that's because you need extra supplies. And so a charge nurse will help you find that if you need it. But you may see a patient come in with it because these can go home. You know, they don't need to be hooked up to anything, but you can't put suction to them without an adapter kit or anything like that. And this one's the same kind of guy. You would just put the chest tube in the chest. Again, these are for really patients who are ambulatory or going home, and they just are going to need constant air venting, even after their lungs won't heal, basically. Their air leaks never heal, and they need constant venting. So some patients do go home with these, and they will go home with these self-contained systems. This one has a one-way valve as well, so that when air goes out, the valve opens and lets air out. And when they breathe in, or when their chest is empty and pulling air in, this will be sucked shut. So those are one-way valves. Again, they're all chest tubes. They're all drainage systems. So let's go back to deep. All right. So that's just for your own information. Again, I'm not going to test you on that, but there may be questions based on, you know, if you see the different systems. What I am going to test you on is definitely knowing the 3 sections of the chest tube and when you're having problems and what's normal. So what to expect and what not to expect from a chest tube, basically. So that's all kind of interesting information, but here's the summary. Here's what's expected. I expect the dressing to be clean, dry, and intact. I expect all connections to be tight and taped like I showed you, because otherwise they will come disconnected and cause an air leak in your system. Chest tubes are never clamped. Make sure they're not clamped. System and tubing below the chest level. Those are expected findings. If they are not, make them right. Make it happen. With the water seal, I expect titling, which is that ball going up and down in the water seal chamber. So when you're looking at the water seal chamber, go back to the camera again. When we're looking at the water seal chamber, titling is that little ball right there. It will go up and down with your inspiration and expiration. Okay, that's normal. That's great. We want to see that. So that's titling. No bubbling or intermittent air bubbling. So when we're looking at the water seal chamber, I should see titling and either no bubbling or intermittent bubbling. Intermittent bubbling is expected if it's a known pneumothorax. Okay. Drainage collect container. I want fluid less than 100 milliliters an hour. If it's draining out more than 100 milliliters an hour, that's like urine output. That shouldn't be coming out of your lungs. That should be just notified, because I don't expect that much drainage on a chest tube. Maybe right after you put a chest tube in, but then it should slow down. If it's continually too much, they're either producing too much effusion or they're bleeding. So we need to notify. When the suction control chamber, make sure your suction amount and that your suction is functioning. Okay. And then what we do not expect, and interventions for what we don't expect. If you have intermittent air bubbling, if no previous pneumo, notify the provider. If there was a previous pneumo, don't waste the phone call. They're going to be like, yeah, that's why I put in the chest tube. So don't do, yeah. Only call them if the intermittent air bubbling is new. Continuous air bubbling in the water seal chamber is always bad. Check the patient, check the chest tube, figure out what's going on, tape the connections or replace the drainage system. And if your drainage chamber is full, you will have to change the system. That is the only time, and that's the other reason that the dries are better than the wets. The dries, you can change the system just by disconnecting and reconnecting a new system. This one, you have to change out the whole tubing, untape the connection, clamp the tubing, and then put it back on. So that's the only time we clamp it, is when we're changing out the drainage system, if we even have to clamp it at all. And then the suction control chamber, if the suction's at the wrong suction or not functioning, we have to fix it. Then know what to expect and not to expect after a thoracotomy. Again, I don't want you calling patient because they have pleuritic chest pain. They had chest surgery. It's gonna hurt. Friction rubs, because when we try to listen where the chest tube is, when we're trying to hear lung sounds and there's a chest tube rubbing right there, we're going to hear that same friction rub that we would hear in the heart. You can't hear past the chest tube, basically. You should hear normal breath sounds if you're listening in the front or to the side, but you're going to get a chest tube rub right over the chest tube. Absent lung sounds over any removed lobes. Remember, if we remove a lobe, it can't ventilate, so you're not going to hear breath sounds. So I don't want you to call the physician and be like, oh my God, he had a left lower lobectomy and I don't hear any left lower breath sounds. He's going to be like, yeah, I took the lobe out, so you're not going to hear them. So that would be something that's a little bit different. If they've taken lobes out, which they will do for cancer, then they will have absent lung sounds over that removed lobe. Atelectasis is normal post-procedure because when they do a lung surgery and they're ventilating them, they don't ventilate them fully. They're trying to cut into that area. So they just ventilate the tops of their lungs, just enough to get oxygen. So the rest of the lungs kind of shrink up. So atelectasis is very common post-thoracic surgery. Don't expect bleeding. They will come out with chest tubes. I don't expect them to come dislodged. I don't expect infection. And if it's a lung transplant or anytime there's transplant, in the first 24 to 48 hours after any transplant, we're worried about them rejecting their organ, which will basically just give us a larger immune reaction. We don't expect respiratory failure. So what do I need you to know? I need you to recognize it. I will ask you a couple of questions about which patients in respiratory failure, which patients worsening in respiratory failure. I will ask you questions, and I need you to know that respiratory failure, hypoxia, low sats, hypoxemia, meaning in the blood, there's low oxygen. You have to get a blood draw to get hypoxemia. Hypoxia is your sat. Hypoxemia is a direct measurement of the blood. So when you draw blood, your PO2 is less than 60, your SATs. I didn't put the SATs on there because people fail at different SAT levels. There's no specific SAT level that tells you you're in respiratory failure. If your SATs are not going well, what will they draw? An ABG to get you these numbers. If your numbers on the ABG come back with a low PO2 and a high CO2, you do qualify for respiratory failure. It means you are not ventilating adequately to pull oxygen in and release CO2. Again, I think you know exactly what to monitor, but that's there in case. This slide is, of course, important because we need to make sure that when they're notifying something about respiratory failure, we're not getting an intervention that's not appropriate. The patient has to be conscious, spontaneously breathing, and able to protect their airway to get BiPAP or CPAP. If your patient is lethargic, not responsive, are they going to get BiPAP? No, they can't protect their airway. Protect their airway means that if they are having trouble or if they get fluid or vomit, they are conscious enough to be able to remove the mask. Because if you keep pushing pressure in when you have vomit or too many oral secretions, and you can't protect your airway, they will just get forced into your lungs and cause a worse pneumonia. So if your patient is lethargic, which they will put BiPAP on lethargic patients, it will usually turn into an aspiration pneumonia. So if your patient is really not doing well and they have a low level of consciousness and you don't think they can protect their airway, BiPAP, don't let them pawn you off onto a BiPAP machine. You say, no, this doesn't look safe. I don't think they can protect their airway because they have to be, and obviously if the patient's not breathing adequately, how are we going to bag them on BiPAP? BiPAP requires you to take a nice breath in. Otherwise, you got to put really high pressures on the BiPAP. And if your patient's not spontaneously breathing, BiPAP is not appropriate. We need to put them on a ventilator and ventilate them. We can't do most modes of ventilation through the mask, really only BiPAP and CPAP through the mask. So that's just basic. If they're awake, conscious, spontaneously breathing, able to protect their airway, they can get non-invasive. If they are unconscious, not breathing adequately, they need intubation. Okay. This is just some, like I said, 60 to 80, 90 to 100, they're guesstimates. They're guesstimates. So they're not very specific. These are the non-invasive positive pressure. I would like you to recognize the non-invasive positive pressure. I want you to recognize that your patient probably has to be headed towards respiratory failure to get these. And so when your patient's on high flow nasal cannula, I don't want to be like, oh, that's normal. It's not. High flow nasal cannula means they need pressure to stay open. That's not normal. That shouldn't be, no one's going home. Well, maybe they are nowadays. They might be going home on high flow nasal cannula, but that is the equivalent to CPAP. A high flow nasal cannula and CPAP are almost equivalent. One's through the nose, one's via a mask. But they are pretty much the same thing because you can put up to 60 liters per minute through your nose. Can you imagine? Yeah, they're getting high pressure. So high flow nasal cannulas are considered positive pressure. They're not very strong positive pressure, probably about 5, maybe higher, not much higher though. It is pressure though. CPAP can go up 5 to 20 milliliters of pressure, of extra pressure, but we don't want to put in a lot of, it doesn't put in pressure. It just holds pressure when you exhale. So it doesn't, it's not effective to ventilation. You can see that holding air doesn't help if you can't get air in. So CPAP's okay. High flow nasal cannula, again, they're not going to push air in. They're just going to hold air as when you exhale. BiPAP will push air in at one rate and then hold air on exhalation. So BiPAP is what most patients in respiratory failure will start with if they are conscious. The inspiratory level is high. The peak or the expiratory level is the low number. So it's usually 12/7, 20/10, whatever they want to do, but one's inspiratory, one's expiratory. And that you can see with Mr. Pig, we had to go to high inspiratories and high expiratories to keep him ventilated. Expected and unexpected with non-invasive, not intubation, but non-invasive. There's a lot of things that are kind of annoying about BiPAP, like skin irritation around the mask, dry mouth. We are definitely putting a lot of air in. Their mouth gets real dry. We have to humidify the system. The mask has to be real tight to hold the seal, especially the higher the pressures are. So you've seen those patients. I don't know if you've seen them or not. They get on their mask. I'm trying to get my mask set up right. But yeah, when they put on their mask, it's only been a minute. It's uncomfortable. Let me. You can come and I don't think you want to wear this one, but you heard the pressure coming out of this thing, right? So when they're got this mask going in, let me see if I can. I'm gonna blow myself across the room. I'm not gonna put this on video. It smells bad. Okay. Seriously. Sorry. Anybody ever seen the patient on BiPAP? It makes about that much noise. And this is high pressure. So it's going to be hard. All the time. That's high pressure. If your patient's on this high pressure, it's not going to work real well. Let's turn it down. Let's turn it down so it stops making all that noise. This is 10 and 5. That other one was 30 and 20, so that was big pressure. This is good. It does feel kind of interesting, but you can see it's like popping out around their mouth. It's uncomfortable. Pushing the pressure in, some patients do well on it, some don't. It's kind of uncomfortable because we're trying to push pressure through a mask and it does blow out their cheeks. It's kind of feels weird to them. If you're tired, you're just going to relax and let the air flow in and out. Was fighting it a little bit. So, but patients are fighting it and it's not ventilating, it's not appropriate any longer. But we do expect a little bit of skin irritation because to get that seal sealed, I'm going to push this into my face really hard to really get that seal tight. And people with nice chubby round faces, they might seal well. People with skinny thin faces don't seal well. There are different size masks. You work with your therapist. They can change the alarms and things. But BiPAP is hard. And some patients fight it. And if it's not helping their ventilation, we're not really going to use it. But skin irritation, because it has to be so tight to really get the seal. So just reposition it every little bit, you know, kind of move it side to side a little bit just to reposition it. Abdominal bloating, well, you saw how much pressure that was putting in. Some of that's going to go down your esophagus, could cause, if you bloat up your belly too much, what's it going to cause? Vomiting, which not good with a mask. If they happen to go, what are they puking into? Boom. Yeah, it's not good. So if they are feeling nauseous or sick from the abdominal bloating that we kind of, it's inevitable with these things, tell them, you know, like if you're going to vomit, take that mask off because you don't want to vomit into that mask and then get it pushed back into your lungs. Mask air leakage is a huge problem. Because, you know, small people don't fit big masks. You have to get the right size for their face. Make sure if your patient is non-invasive or invasively ventilated that you have a bag valve mask at your bedside and that the PEEP valve is on it and set at the same PEEP pressure as your ventilator or your BiPAP, okay? Which one's the PEEP pressure? If it's 20/10, which one's your PEEP? The 10. The positive end expiratory pressure is the lower one, the pressure we're holding in there. So if you get your ambu bag and you get your PEEP valve, you're going to look at your ventilator and see what your PEEP is set at and turn your PEEP to the same or a little bit higher. Because if your patient comes off that mask and needs to be bagged or the ventilator pops apart and you need to bag them, you want to make sure you don't take away any of their PEEP. Because you saw with Porky there, when we took away his PEEP, his lungs just deflated. So we need to make sure that your bag valve mask, always have a bag valve mask handy with the mask on it, because you don't know when they're going to get worse on wherever they are. And this is your emergency supply when your patient's already on ventilator equipment. Make sure you have a bag valve mask with a PEEP valve on it at your bedside. Don't get caught. Your patient's already in respiratory distress. Have your emergency supplies. Prevent aspiration pneumonia. Again, I showed you how easy it was to get an aspiration pneumonia because it's pushing it in. So just make sure that you keep their mouth clean, head of the bed up, reposition them, and keep their mouth as clean as possible and their airway up so that they don't get stuff pushed into their chest. Skin breakdowns, not expected. Aspiration pneumonia is not expected in respiratory failure. It's not expected to stay into respiratory failure. This is supposed to help them. If it's not helping them, we need to move to something else. And then the second else, the other is invasive. And the only two ways to get invasives are through a oral ET tube, which is the big guy, or the tracheostomy, which you have seen is the little guy. You can be intubated for as long as you need to, but they don't like to intubate people for longer than 2 weeks if they can. Some people are intubated for up to a month. It just depends on what their problems are. But putting this tube in and holding it against your mouth and taping it up causes a lot of skin breakdown, causes oral breakdown, problems with the tongue, the sides of the mouth, lots of skin breakdown with these tubes. They are supposed to move them every 24 hours side to side to prevent breakdown. But it's also, which one do you think would be easier to breathe through? The shorter straw. Shorter water straws are always easier to breathe through than bigger, longer straws. So tracheostomies are easier to breathe through for the patient, less irritation. They can, you know, put ice chips in their mouth. They can do things. So if they're going to be ventilated for a real long time, or they're having trouble taking this, you know, getting this breathing tube out, taking the breathing tube out is called extubation. Intubation is putting it in. And then if they're really having trouble getting them off the ventilator, they will probably transfer them from a breathing tube to a tracheostomy, because it's a lot easier to breathe in and out through a tracheostomy than it is through a tiny narrow tube through your mouth or your nose. But you can only do invasive positive pressure through a tube or a trach. The balloon at the base is to protect your airway from getting things down there, but it's not a guarantee. These have to be inflated just right in order to prevent secretions from getting into your lungs. So make sure you're suctioning and doing your oral care, because that's what's keeping stuff from getting into your lungs. Because these balloons, when they're blown up, they're only as good as the balloon. And so, where's mine? I had a syringe. There it is. So let's blow up the balloon. Put this on the camera here for a second. Oop. Oh, we're not going to get to our patients. I never have enough time. But yeah, I just wanted to point out that if you see this balloon, well, the balloon's got a hole in it, but if it was inflated and there was a lot of oral secretions right there, and then it got a leak, guess what? Poop, all that stuff's just going right into the lungs. So do your oral care, and make sure your cuffs are inflated. If you have a question, ask your respiratory therapist. They have a little measurement that they can put on here and see if it's inflated properly or not. So if you're, check your balloon on here, because the balloon on here is equivalent to what's on here. So this balloon is flat and not giving me any resistance, because the balloon in here is flat, not giving me any resistance. If this was blown up and nice and tight, this would be blown up nice and tight too. So it's kind of like a mirror of what's going on with your cuff. If you're ever curious, ask your respiratory therapist, check the cuff pressure, and they will. So the ventilator, again, these are just words that I might give you on the test. So I would want you to be familiar with them. You don't have to memorize normals or anything like that. I just want you to know, if you see the word FiO2, that's just the oxygen amount, what they're getting in. Tidal volume is the amount going in and out with each breath. Peak inspiratory pressure is that higher number. That's the inspiratory pressure in. The peak is the highest pressure on the intake. So basically, if it's higher, you're getting more pressure in your lungs. It's a lot more resistance. And peak is the end pressure. Okay, so just some vocabulary there. But this is what you're going to be tested on, is what do you expect? This is how we maintain the patient. Just like with BiPAP, there's certain things, making sure there's no breakdown and stuff. These are the things that we expect to do and monitor with our patient. These are the things we do not expect. I don't want aspiration. I don't want them to take their tube out. And I don't want them getting a pneumo, because you could see that when we're pushing a lot of air in there, if those lungs are damaged, it's real easy to pop a pneumo. It's very easy for patients with damaged lungs already to pop a pneumo. So we're always looking out for that, especially when we're putting pressures into the lungs. It's much easier to pop a pneumo than if you're passively breathing in and out. So just recognize them, and know what you need to call for. Because when we call, we're recommending interventions, right? So even though you can't go and perform those interventions, I want you to know what to anticipate and suggest. So definitely know your unexpected and what to call for. And the common ventilator alarms, we talked about high pressure, low pressure, apnea, and then the high tidal volume, low tidal volume is basically just a lot of air going into the patient or not enough air going into the patient. You don't need to know the common ventilator modes. That's just for your information. There's a new one now called ARV that certain ventilators can do, but you don't need to know all of them. This is just for your information. If you have a patient in clinical on PC or AC or SIMV, or you can go and look them up and read them over. Let's just look at the questions. I'm going to look at number 1 because we've got definitely more than half the class so far. So let's see what we've got. Chest tube, all right. Right anterior chest, so in the front, second intercostal space for a pneumo. Which of these assessment data is of most concern? So we're talking about things that we're not expecting. Air bubbles appear during expiration. So I would like air bubbles to appear, but when do they appear? When the lungs are full, inspiration. So this is just kind of, like I said, but let's just keep it because we do have intermittent air bubbles. Let's just see. It's supposed to be during inspiration. Continuous bubbling throughout the respiratory cycle in the suction control chamber. What if we had, suction control chamber.
That's fine.
Continuous bubbling, that's fine. So when we looked at the first one, we were like, there's a word wrong. It's supposed to be on inspiration that we see the bubbling. So I'm not wild about it, but I'll take it. Then the second one, this one's okay. Remember, we told you the only place the continuous bubbling is okay is in the suction control chamber. So that's perfectly okay. That's actually good. 250 drains after the chest tube insertion. I don't like that. That's a lot of blood loss. 250 milliliters of blood. It's almost a whole unit of blood. That's a lot of blood. So I'm not loving that. But maybe if they had a pneumo, I don't know. Let's just look. Client indicates they has pleuritic chest pain with every inspiration. Do we expect that? Pleuritic chest pain means pain with a deep breath. Well, if you had a piece of plastic right next to your delicate lung tissue, would it hurt? Heck yeah. Heck yeah. So now I'm like, wait, I'm okay with that. I'm okay with that. I'm not okay with that. I'm not okay with that. What's the question say? After the chest tube, which is of most concern? Well, that's not a concern because that's okay. That's not a concern because that's expected. So these two, continuous bubbling, expected. Client indicates pleuritic chest pain, expected. So we're going with these two problems. Of those two problems, which one's more worrisome? I'm worried about the blood. And that's just because of the quantity of blood. Because what are you expecting to come into the drainage chamber with a pneumothorax? Air and maybe a little bit of serosanguinous pleural drainage. I don't expect blood. He has a pneumo. The question didn't tell you he had a hemothorax. So don't go down the whole thing and say, well, if he had a hemo. No, the question told you pneumo. Not expected, very concerning. What do you think that means? When he put the chest tube in, he punctured something. That's a bleed. You need to report that. That's the most concerning. Okay, so I wanted to go through that in case there was some concerns about it, reading the questions and stuff. Early signs of acute respiratory distress. I would look for, remember we said early was tachycardia, tachypnea, fine crackles. None of those are there. All right, well, let's go next. All right, this is failure. Elevated respiratory carbon dioxide is at failure, so that's kind of late. We're in failure at that point, so that's late. Hypoxia not responsive to oxygen therapy. That means you're going up and up and up and up and their sats are staying the same. That's before you go into failure. So yes, that one. Metabolic acidosis, that's failure. These two are failure. And severe unexplained electrolyte balance, that's not even related to your lungs. That's a kidney problem. So the only one that would be early would be the hypoxia because that happens before we go into failure. Does that make sense? We're going up and up and up, sats aren't changing, and then we start to see the elevated carbon dioxide. Oh, actually metabolic acidosis isn't even right. It would be respiratory acidosis. So there's problems with all of these because they come later. This is the earliest one on the list. COPD exacerbation, respiratory failure, mechanical ventilation, left pneumo, got a chest tube. So what do? I like that. Sure, we're supposed to monitor the air leak in the water seal chamber. That sounds right. Clamp the chest tube. When do we clamp the chest tube? Which means putting this big clamp on. When do we clamp the chest tube? Never. Why is it there? The only reason it's there is if you have to change the drainage container. If you want to kind of, and I don't even use the clamp. I just kink it with my hands so I don't forget to unclamp it after I've changed the drainage container. We don't clamp the chest tube because then air, blood, fluid can't get out. It can't do its job. It's like clamping a Foley. Don't do it. We shouldn't clamp the Foley. The only time you clamp it is changing the drainage containers, and then I wouldn't use the clamp. I would just kink it. And the other time would be if the doctor orders it. Okay. The doctor might order it in a couple of situations. Sometimes if they have a large hemothorax, they want to drain the hemothorax, but then once you drain all the blood, the bleeder might start bleeding again. So sometimes they use that hemothorax to act as pressure on the bleeder. So sometimes they might say, let 250 of blood out and then clamp it. That's the only time you can clamp it is when the physician has written an order to clamp it after a certain amount. So never, ever, ever clamp a chest tube unless you have a physician's order or you're training the drainage system. Okay, so don't clamp chest tubes. So we don't clamp the chest tube if an air leak is seen, because if an air leak is seen, we want that air getting out. So don't clamp it. Discourage coughing and suctioning. Do we want to discourage a patient from coughing and suctioning? Never. If they can do it, we want them to do it. Keep the chest tube at the level of the chest. No, it needs to be below. So as we go through there, This is yes, no, no, no. So we go with monitor. Female client with multiple trauma, ARDS, earliest sign. There it is. That's the one we were looking for in the last question. Crackles and tachycardia and tachypnea are our earliest signs, then hypoxia, and then respiratory failure. That's how ARDS progresses. So I would be looking at crackles and tachycardia. This would be after crackles and tachycardia. So that's just a little bit difference depending on what options you had. Because the other one didn't have crackles and tachycardia, we had to move to the next option as the earliest. Now we have crackles and tachycardia, this one becomes the second best. Okay, so just kind of clarifying that. If you have issues with this, and this would be late, it would be decreased level of consciousness. I would again write this out, no abbreviations on your exam. Hypocarbia, what does that mean? Hypo means low. What's carbia? What are we reading? Carbon dioxide, low carbon dioxide. That's not usually found in respiratory failure. It's high carbon dioxide. So that would be wrong anyway, even if you wanted to call it that. That would be a late sign, but it's also wrong. So when you're looking at 4 and you're not sure, instead of making an argument for a wrong answer, look at them like they are kids or troublesome boyfriends or something. One of you is lying to me. One of you is lying to me. I'm trying to figure out which one of you is lying to me. And if you wanted this one, this makes it a lie. If you wanted this one makes it a lie. This is earlier. And if you wanted wheezing and stridor, that has nothing to do with ARDS. That has airway. That would be with asthma or airway constriction. It has nothing to do with ARDS. X-ray, bilateral whiteouts, ARDS, symptom results from. So I won't put patho questions usually on your exam. This is for me to assess whether you understand the topics or not. It's the increased pulmonary capillary that makes fluid just rush into the lungs and fill up so fast. So that's the pathophysiology behind it. People might have put cardiogenic shock because that's one of the severe conditions that can lead to ARDS. So I wouldn't use this on a test. I think cardiogenic shock, renal failure, any place where you've got a lot of fluid overload could cause ARDS, but the actual pathophysiology is the increased permeability. Don't stress too much about that. I don't put patho on the exam, but if you didn't understand that, go back and read why. COPD, precise oxygen. What type of oxygen system would we want for precise oxygen delivery? The Venturi mask is the only one where we can actually dial the actual amount. The other ones, remember that little respiratory little guide that's up in the sim lab that says nasal cannula, 1 liter, 2 liter, 3 liters is equivalent to a certain amount of oxygen. We're kind of guesstimating because we're basically diluting the oxygen from the wall with room air. So it depends on how big your holes are, and they're not very precise. They give you anywhere, like simple face masks, are anywhere from 40 to 60%. It's not real precise. That's, again, not going to be on the test. I just wanted to see where we all were with it. So when you're saying face mask, that's just an open face mask with holes. We could be pulling anything depending on how big the patient's breathing. Venturi, though, does dial and changes the oxygen level as it enters the mask. And so we get precise oxygen. You'll also see those with some of the face masks. They will have a dial, a percentage of oxygen. That's precise flow. Otherwise, if you just stick a mask into the wall, you could be getting anywhere on a non-rebreather from 80 to 100, and on a simple face mask, anywhere from 40 to 60. So we don't know. You just kind of guess. And so if you want it precise, you do have to have something that actually dials the percentage of oxygen. That's the Venturi mask or anything that's dialed. So that's just a nice to know. Bronchoscopy and biopsy, what would you, so we want something that is not expected. Bronchospasm is not expected. Not expected, I would report that. Dry cough, expected after you've been irritated and you've had a scope down your vocal cords, you've probably coughed for a while. Blood-streaked sputum, he had a biopsy, they cut a little piece of the lung out to send it off. They might have a little bit of bleeding afterwards and it would come out in your sputum as blood-streaked. These are expected. Bronchospasm is not expected. That is a worsening cue or a non-expected cue. And blood in the urine has nothing to do with lungs at all. That's a whole nother problem. So if we are watching the patient after bronchoscopy, I would call about the bronchospasm, because you're going to need something to treat that. Difficulty breathing, accessory muscles, diaphragm. This should be accessory muscles. You could even use diaphragmatic breathing, but that's not always. Diaphragmatic breathing means they're abdominal breathing mostly. That's not always toxic. Babies abdominal breathe, some adults do. A lot of COPDers, you see more abdominal breathing. So it's not always difficulty breathing, but use of accessory muscles, the clavicle area and stuff, that is always difficulty breathing. 1 day post-op, pneumonectomy, lying on his right side. So he had a left pneumonectomy. They removed part of his left lung. He's lying on his right side with the head of the bed elevated. The nurse assessed his respiratory rate. What do? It's 32. It's a little bit too high. So he's laying on his right side. Is that the side we want on a pneumo? We like the affected lung up. So if he had left surgery, we would like to expand that left lung as much as possible. So we want the left lung up. So we would like him to be on I don't want to change his side. I think his side is good. He should stay on his right side, but he's elevated at 10 degrees. Maybe he could sit up a little bit more. I would like to elevate the head of the bed. Do we want to get him out of bed?
No.
Not with a respiratory rate of 32. Cross that out. Measure the client's O2 set. Could. What makes, and then give him morphine.
No.
Not at this point. It doesn't say anything about pain. If it gave you a pain level of 10 out of 10, that might be appropriate. I didn't say anything about pain in the question, so don't pick it. It's not an issue. Don't make up things. This is a question about what are you doing about the respiratory rate of 32? Either elevate or measure the O2 sat. Which one will help him the most if he really is having trouble? Elevating the head of the bed. So that's just, I'm trying to go through and just kind of do some NCLEX question things. But that's why this one goes first, because that will actively help him. This one gives you more information, but doesn't actively help him. And so that's the distinction on that one. Some of these are harder than your usual test questions. A lot of these off the quizzes might have been test questions that I removed because they had bad statistics, but I still want to talk about the question because it's a good question for NCLEX prep. And that's why this one wins over this one, because it's an airway problem. And when you have a high acuity problem or a worsening condition, you need to take an action first. And a respiratory rate of 32 after a chest surgery, that's too high. It could be pain, but I didn't mention this pain. So I don't want you going there. And so I want you to do a respiratory intervention. This one will help more than that one. And when you have to narrow down, what do you do first? That's usually a quick, fast nursing action that will help your patient until you can get more help. And so when you see what do you do first, they're usually trying to get you to do a quick intervention that will assist your patient. Don't pick things that won't help your patient. When they're asking first, that means your patient probably needs something quickly. What would it be? And you can't do physician interventions. You got to do quick things that you don't need an order for. And that would be sit them up. Considered respiratory distress. This shouldn't be hard for most people. A lot of people, you can just go to whoever's on the highest oxygen because they're probably the one in respiratory distress. If he's got low sats on high oxygen, he's the winner. The only time that your sats and level of oxygen do not matter is with a COPDer. COPDers could be considered respiratory failure on lower oxygen, but none of them are COPD. Or that I know of, it didn't say. Most common cards of Oz, this is just sepsis, terrible pulmonary doc, oh, that's funny. Sepsis is probably the most common, then followed by aspiration of gastric contents. Oxygen toxicity is keeping your oxygen at 80 or above for a real long time. Oxygen toxicity causes scarring of the lungs. So that's where everybody's like, just put them on 100% oxygen. And I'm like, that's great until you've been on 100% oxygen for a week and now your lungs are scarred from oxygen toxicity. So there is such a thing, just like there's DIG toxicity. Every drug can be too good. And oxygen 100% for a long time is not good for your lungs. Which person is most likely going into respiratory failure? Again, we're looking for criteria of respiratory failure. I don't have any more details about the amount of oxygen he's on, so I can't put him in respiratory failure unless I have more detail. ABG 745, 735, and 730. Are we seeing a downward trend on that? We're getting a more acidotic trend. Be a little worried about that. Short of breath while eating. That's with activity. I would be concerned, maybe. COPD who has distant breath sounds. Is that worrisome? What does distant mean? You can hear them, they're just real quiet. You can hear them. So that means we do have air exchange. It's just kind of distant. But that's usual for COPDers. They have a lot of trapped air that doesn't move back and forth. So it might be hard to hear their air movement in and out. So I would say that's expected. These two are unexpected. Which one looks worse to you? The pH, the acidotic patient, he's in respiratory failure. This patient might be headed that way, but he's not there yet. So we would go with the pH patient. And I'm sorry if you got all these right. That means you're doing great. Chest tube, drainage system, continuous bubbling in the water sealed chamber. Is that good or bad? Bad. That's bad. The water sealed chamber should never have continuous bubbling. The only thing that should is the suction control chamber. So continuous in the water sealed chamber, not good. So what does it mean? It means there's an air leak in the system. So do we reposition them, increase drainage, check the drainage system for an air leak, or continue to monitor them? Check it for an air leak. That's the answer. Continuous bubbling in the water sealed chamber means an air leak, so check it. Good job. 50 milliliters of serosanguinous fluid, fluctuation of water in the water sealed chamber, bubbling in the suction control chamber. You see any problems there? 50 milliliters of serosanguinous fluid post-op. That seems like decent amount of drainage. It's not too much. And serosanguinous, it's not bloody. Fluctuation of water in the water seal chamber. That means that in your water seal chamber, this little bubble kind of goes up and down with each breath. Good, bad. Good. Means your breathing you've got a good breath. You've got a good tidal volume. So that's fine. Patient bubbling in the suction control chamber. We're talking about suction control chamber. That's okay. Continuous bubbling in there is okay. So we've checked everything and it's all okay. So you can document your findings as normal. If it was bubbling in the water seal chamber, that would be bad. We would check for an air leak. We don't need to notify the physician about the training. And milking the tubing. You shouldn't see this on a thing because it's long gone. Milking the tubing used to be where we'd have the chest tube hooked up. And if we want to get drainage out of there, we would take it, we would clamp it, pull the tubing straight, and then let go. And what does that do? It creates more suction. The evidence base said, stop. That was causing terrible tissue damage on the inside of the chest. So we are allowed now to massage the tubing. So if you have, and this is from like where you have like hemothoraxes and things draining, you can get clots in your tube that will close up. You know, if you see a clot in your chest tube, where my chest tubes go? If you see a clot in your chest tube coming out and you see that clot right there, you just want to pull it out. And that's what the nurses would do, is they would milk the tubing to try and get the clot down. But it was causing, there's a lot of air holes on the side here. It was causing tons of tissue damage around those air holes because we were increasing the pressure to too high. So don't milk it. If nurses tell you, if you're on the ICU or you're in the ER or you're in a floor where they're like, oh yeah, just milk those tubes. That's an old nurse and we're not supposed to do that anymore. You're allowed to massage the tube and break up a clot, but you can't suck the clot out of the tube. So that's what that means by milking the tubing. We don't do that. You might not have known. That's fine because you shouldn't know. We shouldn't be doing it. Patient recovering from a pneumo has a chest tube. What is appropriate? Intermittent bubbling in the water seal chamber. That is appropriate. This is always too much drainage. There should not be drainage from a pneumo except for air. Maybe a little serosanguinous. Position to the chest level, no. Chest tubes need to be below and they're not all. So it's just the intermittent bubbling. You got to get the patient around. Chest tube becomes dislodged. Oh no, the chest tube popped out. They have happened because they are sutured in place, but they're sutured to the skin And if a patient gets out of bed and that's all the way is hanging on the bottom of the bed and you forget to move it, they pulled them out. It can happen. So what do? It's three-sided dressing. So we want the sterile three-sided dressing. Don't reinsert. Don't keep the site open to air. And yeah, you want to stay with the patient and monitor the vital signs while another nurse notifies the physician. But does it ask you to do all that apply? No, it does not ask you. If this was a select all that apply, I would take both of these. But it's not. We have to pick the best one. And if you could only do one of these things, which would be the best one? This one. So when you're going, what do you want to do first, or what do you want to do emergently? Those are usually things that you do right there in the room without leaving that will help your patient. So that's why we would place a sterile dressing over the site, because that will help a lot more than just monitoring them and standing there going, And people are like, well, I would do both. And I'm like, yeah, but the question is trying to figure out if you're safe. It wants to know if you know the right first thing to do. Yeah, you can do both when you're out in practice. That's a select all that apply. I would, yeah, and they should have dressing supply. Yeah, I would keep it as part of emergency supplies. 100%. I also would bring a second drainage container in the room. Let's just keep that over in the corner, because if this cracks or this starts breaking, I don't want to have to go look for another one. And if it has too much drainage, don't open it, but you can keep them at the bedside. I would keep those supplies. They are great emergency supplies to have. Good question. Which of the following increases the patient's tidal volume or air in and out while receiving BiPAP? Which one will help increase the patient's breathing in and out? Exactly what we had to do to Porky here. When we had him on a rate of an inspiratory pressure of 10, he wasn't ventilating. He needed more help. So we had to increase the inspiratory pressure, and then we saw him blow up. So increasing the oxygen amount does nothing to pop open your lungs. And it might not work. It's just an extra drug. And changing to CPAP mode, BiPAP's more efficient than CPAP. So we wouldn't change to CPAP. Good job, guys. I think you guys are getting it. Select all that apply. Ventilator-associated pneumonia. How do we prevent it? Frequent oral care? Yes. Germs leave the mouth, and that's where now they have epiglottis suctioning. They actually have suctioning now that is another suction that goes in here and suctions the back of the mouth above where the tube is in place. So when this balloon is blown up, it's in your trachea. But what about all this stuff right here? There's stuff spilling back from your mouth, from your oral cavity and your nose and drainage. And this is all open. Your vocal cords are being held open by the tube. And so all that stuff just sits on the top of the tube. And if we lose air, it goes down into the lungs. So one of the things that we do is frequent oral care to keep your mouth as clean as possible, so that if your saliva drops back onto here, it's at least a little bit germ clean, you know. So they might get chlorhexidine rinses and stuff. And that's just to keep the bacteria in the oral cavity low so that it doesn't get into the lungs. Suctioning the tube every 15 minutes. Is that helpful? That might be a little bit too much. This is so broken. Yeah, that might be a little too much. We suction every hour or as needed. If they need it every 15 minutes, we will do it every 15 minutes. But we're not going to do it every 15 minutes as a standard of practice. You don't want to keep suctioning them every 15 minutes if they don't need it. So that's just kind of like, just do it every 15 minutes. No, that's only if we need. Head of bed greater than 30 degrees. Yep, that's good. And turn the patient every 2 hours and deliver percussion and vibration. That's just where you're patting the chest and mobilizing. So this is mobilizing secretions. 100% that's okay. Because if we're mobilizing secretions, bacteria have a hard time growing in them. So frequent oral care, head of bed, and turn the patient and do mobilized secretions. We don't need to suction very often. Endotracheal suctioning is every hour or as needed. Have you guys seen the, this is just an FYI for you. This is a sputum trap. If you need to get a specimen collection while your patient's on the ventilator, you can put this in between when you suction. Let's see, gotta get a suction cap. This thing's hooked up to suction on the wall, and you just suction into the bucket on the wall. But if you want to get a sputum sample while your patient has a breathing tube with this thing in, you just disconnect the suction. And where'd my sputum trap go? And you hook this up to here, It's just honestly like just a little thing that goes in between your system here. And then when you suction your patient, where's the sputum gonna go? It's right into your collection container. Oh, it's so nice and it's so easy. You just suction your patient and all that gory sputum goes into your collection container, and then you can just take it off and send it to someone out. So that's, if you ever see, if they ever talk about getting sputum cultures while your patient's intubated, I just think that's a fun toy. I didn't have it. Anyway. All right. So that's you will have a couple questions about ventilator associated pneumonia, because that is one of the problems that we have with an ET tube that we do not expect. Low pressure alarm. You guys got that? Low pressure means something's disconnected. Check it. All the other things cause suction the patient. That would be because you have obstructions. We wouldn't be getting a low pressure alarm. That's for high pressure. Check the ventilator tubing for leaks of low pressure. What is sedation going to do about your pressure? Nothing. Don't increase the sedation. Your patient has an air leak. Sedation's not going to help. And the reason we would increase sedation is because your patient's fighting against ventilation or coughing. And that's why we sedate your patient, so they can receive the ventilation and not fight it. Fighting the ventilator or coughing against the ventilator will cause high pressure. So that's an intervention for high pressure. Empty out the water condensing in the circuit. This just means that this is all humidified warm water. And so it does condense in the bottom parts of this circuit. And if there's enough water in there, that may seem like obstruction to the ventilator and will cause high pressure. So usually water just causes like an annoying high minute volume or low minute volume because it thinks the patient's breathing because it's feeling water move back and forth. So we're constantly, that's why there's little bags. I took the bag off the system, but there's always little bags at the bottom of the circuit so that you can take any condensate and dump it out of the circuit, because that will change your ventilator readings if you have a lot of water in that tubing. So that's what that means. But the true thing is check it for leaks because it's low pressure. High pressure alarm will not trigger with. It's those reverse questions to make sure you're reading. What does stimulate high pressure? Biting?
Yeah.
Yes, that will be high pressure. That's kinking the tube. Pulmonary edema? Yes, because it's trying to push fluid through lungs. It does increase the resistance. It might give you a high pressure alarm. Endotracheal cuff leak. No, that's going to be less pressure because when it puts air in, some of it's leaking back out around the tube. That will cause a low pressure and air leak alarm. So that will not trigger with a high pressure alarm. Decreased lung compliance or stiff lungs is going to increase the pressure that it has. And remember, this is resistance to pushing air into the lung. So resistance, resistance, resistance. Yes, those will trigger high pressure. The only one that won't is an air leak. So it's a backwards question. Good job. I think that's really what I'm going to be asking you about. ARDS, effusions, hemos, pneumos, how to treat them, chest tube, and then all those different